So we're trying to improve the care, at the national level, and we're trying to prevent suicide as one of our main objectives. Thank you.
Thank you. Can I go to the next, Amy, maybe? Just your name?
Hi, everyone. I'm Amy Tausch. I'm a consultant in mental health here at the PAHO regional office in DC. I just wanted to thank everyone for joining us. I've been incredibly impressed with all of you, but we want to hear from you right now.
Hi, everyone. I'm Jansen Foster with NIMH. I think one of my lessons learned yesterday was really more subject specific on the use of pesticides as means. And so I really learned a lot from that panel, especially yesterday.
Buenos días a todos y a todas.
Good morning, everybody. It is a pleasure to be here with you. This is Paulina Andrade, professor and researcher at the UNAM in Mexico, and I coordinate the suicide prevention program in Mexico. The main lesson I learned yesterday is that suicide is a problem that we all have to address, and it's important that each one understands his or her role in that joint activity. Thank you.
To come to the front for us to hear you. Thank you.
Good morning, everyone. My name is Masfin. I am program officer at the NIMH, and I wasn't here yesterday, unfortunately, so I cannot answer.
Good to have you.
Good morning, Holly Campbell Rosen. I'm from NIMH as well. And I think one of the things that stood out to me yesterday is in the pesticide panel, I think Dr. Manuera just said something like, laws are not the solutions, we are. And that stood out to me in terms of collaboration and how to, solve things.
With Leo.
Gracias, Claudina. Buenos días, mi nombre es
Claudina, good morning. Leonardo Cubillos. I work for NIMH, National Institute for Mental Health of the US. What I learned most yesterday is that the assumption on which this event was originated, that researchers can learn from policymakers, and policymakers can learn from researchers and work jointly. That's true. Personally, I identified many points of learning and many points of potential research going forward. Thank you very much.
Good morning, everyone. Vidya Vedam. I'm a senior advisor at the Center for Global Mental Health Research at NIMH, and it's a pleasure being here, and thanks everyone for joining us. The one lesson learned is there's so much more to do for me, and that was really stark, regardless of whether it's policy or implementation of actual strategies or the research that needs to be done. Thank you.
Hi, Stephen O'Connor again from NIMH. I think the thing that I was struck most by was the potential for advancing suicide prevention by bringing together these important partners from across different industries and bringing to bear the expertise of the researchers as well, who really are leading the field in their respective areas in terms of addressing some of the most at-risk populations. And so for me, I was just really appreciative of the opportunity to bring everyone together. This is a really unique opportunity. I'm glad that we're making use of it.
Thank you, and good morning from me as well. I'm Gamini Manuira, consultant for Center for Pesticide Suicide Prevention, University of Edinburgh, UK. My take-home message yesterday was how important to forge connections. Congratulations, Dr. Renato and your team. It is so important. Just sharing your same feeling. Thank you.
Good morning, everyone. I am Dr. Timothy Morgan, the Director of the Mental Health Unit of the Ministry of Health of Guyana. Yesterday was very important, and I learned that tackling the issue of suicide and related issues, suicide prevention as a whole, it's very multifaceted, and sharing or bridging connections with different persons working in the same field actually is very valid so that we can all holistically address the issues of suicide prevention.
Good morning, everyone. I'm Mark Senior. I'm an associate professor of psychiatry at the University of Toronto and at Sunnybrook Health Sciences Centre. I think we heard a lot of diverse presentations yesterday, but if there was a theme that kept coming up over and over again, it was that we know how to prevent suicide. We just have to do it. And I think that's different than what we might have heard at a conference 20 years ago. And so I think we know what we have to do. We have to implement all of the strategies that we spoke about, and I look forward to doing it with everybody. It's an honor to be here.
Good morning, everyone. My name is Hazel Othello. I'm the Director of Mental Health in the Ministry of Health in Trinidad and Tobago. I think the thing that resonated with me the most yesterday was actually from the same panel that I was in, where I can't remember her name, sorry about that, but the journalist who spoke and developed the training module in responsible reporting, what she said really resonated with me in terms of the importance of how policymakers and mental health service providers relate to members of the press. It struck me really because the reports that we prepared have traditionally referred to violations of the best practices. And I think that's something we need to change in our report, because they're not violating anything, they're just doing their jobs. And we could rephrase it differently, probably reports of concern or something like that, that doesn't have that stigmatizing feel about it. Because I don't think we could call a journalist and tell them they violated or something, you know, so that that really resonated with me, and I thank her for it.
Thank you so much. Colleagues from the back, so we start with you and then we go ahead.
Buenos días, colegas. Mi nombre es Jaime
I'm Bayona, Senior Health Specialist at the World Bank. What impressed me yesterday was actually seeing the work of more than 10 years by different countries addressing a quite difficult topic. The lesson for me is that this collaborative work among countries helps each and everyone to mainstream the achievements in its own work, the achievements of the neighboring country. That's a big lesson. And for me, it will be very important to take this experience to the region where I work. I'm learning a lot.
Regional Adolescent Health Advisor at PAHO. I echo some of the things that were already said, opportunities and challenges, and the need to do more and to do it better.
Hola, buenos días con todos.
Gabriel Ordóñez, human clinical psychologist. I work for the Public Health Ministry in Ecuador. My responsibility is very large, so I have a long list of positions. I'm National Director of Prevention and Control Diseases of Non-Transmissible and Mental Diseases. I envy those that say National Mental Health, National Director. I have 4 hats. I'm very happy to be here. And my takeout from here is that this is a social phenomenon which is equal for different countries with different realities and different methodologies, and all that, the wealth that contributes. Thank you very much.
Good morning, everybody. My name is Reed Harrison. I'm with the Business Council for International Understanding. One of the main takeaways in a larger group of takeaways for me yesterday was just the difficulty in accessing capital and budgets to intervene. And while mental health and suicide prevention is not a health issue and we're treating it as such from an intervention standpoint, we need to do some similar strategies when engaging different ministries of labor, agriculture, education from a budget standpoint, in addition to the intervention standpoint. And I think there are some great examples from the adolescent panel yesterday and from the pesticide panel about interventions, but treating sort of a similar approach from the budget stream that goes through those ministries as well.
Thank you. Two more. Just come to the. Oh, thank you, Mechi.
Good morning, everyone. Brandon Court, Director of the Center for Global Mental Health Equity at George Washington. And what stuck out to me was we talk about the data gap in surveillance around suicide deaths, but I heard a lot yesterday about the data gaps in surveillance around suicide attempts and suicide survivors, and that discrepancy between 20 attempts to one death. And if we can get more accurate data on that, that seems like a key population to intervene with. So really enjoy the presentations.
Hi, everyone. I'm Ashley Hageman. I'm a professor of public health at Yale University. In addition to what all the others have mentioned, one thing that struck me was from so much of the surveillance data, there were so many ethnic disparities that were really highlighted in stark ways, nearly in every country that presented some of the surveillance data. So that was really interesting, and also other opportunities for intervening.
Good morning, everybody. My name is Mara Reep, and I'm the Senior Mental Health and Psychosocial Support Advisor sitting in the Bureau for Global Health at USAID. I found yesterday very, very interesting, all the panels, so congratulations actually to the panelists for great presentations. What I found most interesting was the context of suicide in the Americas, and how it's actually interesting that this is the one part of the world where the incidence is actually increased. And I really enjoyed also hearing about the different approaches that countries have taken in responding to suicide. Thank you.
Good morning, Jerome Gallia, Agency Mental Health Coordinator at USAID. And before yesterday, I did not know about the Live Life implementation program. And so I'm interested in learning more about that, seeing how we can use that and incorporate that in our programming at USAID. I think you walked in.
Well, thank you so much. My name is Ciro Leal. I'm alternate representative here at the Mission of Brazil to the OES in PAHO. And I think what became even more interesting for me since yesterday is the interventions that are not necessarily seen as directly aimed at suicide prevention, that common sense will not see that. So I think there's a long way for PAHO and for all involved to promote those ideas and to show the links between these interventions and suicide prevention. Thank you.
Thank you so much. I think we have done, Mechi and we have just introduced yourself, because I know you guys have done a great job. Yes.
Thank you. Good morning, everyone. My name is Catalina Ortuzar. I am a psychologist and a mental health consultant for the PAHO Regional Office.
Good morning, everyone. My name is Mansoura Turaji. A nurse, a public health practitioner, and I'm also doing some work here at PAHO. It's nice to meet you. And just to add real quickly, to echo everything that everyone has already mentioned, but I also found this very engaging because we get to learn from the countries as well. It's a bi-directional, what would I say, multilateral engagement. While we're learning from policy, research, and practice, and I feel like we learn from different diverse perspectives that we can incorporate in implementing and developing strategies to prevent or reduce suicide. Thank you.
So much. So Stephen, over to you. I do not intend to. We miss.
Did we have one?
One. Oh, yes, pardon, por favor.
Hola, mi nombre es Pedro Bernal.
Pedro Bernal from the Inter-American Development Bank. I'm health economist. I thank you for the invitation because I have learned a lot in the sessions I was able to attend. And my takeaway is that even though suicide is a multifaceted and complex problem, there are feasible interventions And I think that there's a more hopeful note. I ever liked very much Chile's example of a national policy implemented for many years. So the challenge is how to implement policies in environments with fewer resources. We have a road ahead of us, and we have to see how to walk the walk. Thank you very much. This concludes the part, and we will have the opportunity to dialogue during the breaks. Stephen, you have the floor.
That was wonderful, and thank you everyone for sharing your thoughts. So now I would like to invite Dr. Renato Oliveira, Chief of the Mental Health and Substance Use Unit at PAHO, and our panel and speakers to the head table. The focus for this panel will be on improving early identification, assessment, management, and follow-up for people affected by suicide. Okay, so the panelists are welcome to join Renato.
Thank you so much, Stephen. If the panelists could come to the head table and join me, Dr. Richard McCone, Dr. Pamela Espinosa Mendes, por favor. Gracias. Two of our panelists will be joining us. One has sent us a video, and the other panelist is joining us online. So let's start by reminding ourselves that early identification, assessment, management, and follow-up are really crucial to ensuring that people affected by suicide receive the support and the care that they need. This panel presents research, best practices, and current initiatives on strengthening services and care, especially in healthcare settings, but also in the community for people who are at risk of suicide, or that have attempted suicide, or that have been bereaved by suicide. The focus of the panel will also be on screening, early detection, crisis services, and post-vention. So the first panelist, and I will be introducing one by one before they speak, is Dr. Lisa Horowitz. She's a pediatric psychologist and a senior associate scientist at the National Institute of Mental Health at the NIH. Dr. Horowitz received her doctorate in clinical psychology from George Washington University, completed a pediatric health services research fellowship at Harvard Medical School, and obtained a master's in public health at the Harvard School of Public Health. The major focus of Dr. Horowitz's research has been in the area of suicide prevention in the medical settings that involves validating and implementing tools for clinicians, such as the Ask Suicide screening question. She's one of the co-authors of the Blueprint for Youth Suicide Prevention, released by the American Academy of Pediatrics this past March. So if colleagues can help me to put her presentation on the screen.
I'm a pediatric psychologist and a suicide prevention researcher at the National Institute of Mental Health intramural program. And I have the privilege of being able to do this video for you, and my apologies that I can't be there in person. Because I work for the federal government, I'm going to put up this disclaimer, but I also have no financial conflicts to disclose. And this is a picture of the NIH where I work in Bethesda, Maryland, in the US. So I'm sure over this 2-day conference, you've been hearing the suicide epi. I just want to put up that the majority of suicides occur in low and middle income countries and focus on youth. It is the 4th leading cause of death among youth ages 15 to 19. And what we don't know so much are about the younger kids under 15. In the US, it is the 2nd leading cause of death, the 2nd reason why kids die ages 10 through 24. So my research team's research takes place in the medical setting. And the reason we chose the medical setting was if you look at death registry studies around the world, what you find is the majority of people, not only adults, but youth who die by suicide, visit a healthcare provider months, sometimes weeks before they die. But the problem is that they don't walk into a doctor's office and say, I want to kill myself. And if someone doesn't ask them directly, are you thinking of killing yourself? They most likely won't talk about it. So the majority of suicide attempters go unrecognized because the majority of medical settings do not screen for suicide risk. Now, this is data from the American Academy of Pediatrics, the AAP, and they surveyed pediatricians. And what they found was this is very much a real issue showing up in the pediatric clinics, outpatient offices. 92% reported that they ever had a patient disclose suicidal ideation. 80% had ever had a patient either attempt or die by suicide. And almost half of the pediatricians had a patient attempt or die by suicide within the past year. So it's a very real issue showing up in the medical setting. So our research team asked, can we save lives by screening for suicide risk in the medical setting? And we think the answer to this is yes. So we developed a suicide risk screening tool called the ASK, or the ASQ. It stands for Ask Suicide Screening Questions. The study took place in 3 pediatric emergency departments in Boston, Massachusetts, Washington, D.C., and Columbus, Ohio. And we oversampled medical patients and infused the sample with psychiatric patients because we weren't sure in 2008 that we were going to, if we just used medical patients, would we get them reporting suicide risk? And from that study, we created the ASK, which was compared against a gold standard, the suicidal ideation questionnaire. The ASK had very strong psychometric properties. It had good sensitivity, which is the true positive rate, almost 97%. It had good specificity, 87.6%, which is the true negative rate. And that's one thing that limits false positives when you're giving a suicide risk screening tool. And the negative predictive value was very strong, 99.7%. And compared to the gold standard, when the ASK said somebody was negative, the gold standard most likely said they were negative too. This is the ASK is meant to be very blunt, very direct. In the past few weeks, have you wished you were dead? In the past few weeks, have you felt that you or your family would be better off if you were dead? In the past week, have you been having thoughts about killing yourself? And have you ever tried to kill yourself? If the patient says yes to any one of those 4 questions, they're a positive. And then they're given the 5th question, the acuity question. Are you having thoughts of killing yourself right now? What we know from big data and big data sets, there's one study I can think of that has over 90,000 asks given to young people. The majority of patients that show up for medical reasons, so universal screening, are going to look like this. So 90 to 97% are going to screen negative, and it's going to be 20 seconds and you're done. And we know from this data that universal suicide risk screening is feasible. But if you screen positive, there's 2 ways to screen positive on the ASK. So if you say yes to 1 or more questions, and then you're given that 5th question and you say no, that's a non-acute positive. What we know again from these data sets are that 99.5% of the positive screens for medical patients are non-acute positive, meaning it's good that you detected that they're at risk for suicide, but it's not an emergency. However, every practice should be compared for that acute positive, which is a yes to question 5. So the ASK has been validated through research and multi-site studies in the inpatient medical surgical unit, the outpatient primary care and specialty clinics, and in adult medical patients. These places in black have ongoing studies. The ASK has also been translated into over 23 different languages and validated in some of them. This is all available in the ASK toolkit, and the website is on the bottom of your screen. So what happens when a patient screens positive? Well, here's what should not happen. And this is really important, right? Because of those data I just showed you. It is so important that we not treat every person who has a thought about suicide like they're an emergency, right? Because what happens often in the United States is if somebody screens positive, they're sent to the emergency department, or if they're in the emergency department, they're put in a paper gown, they're given a very costly one-to-one sitter, and now the patient feels punished, right? So this is not a good patient-centered way to screen for suicide risk or to respond to suicide risk screening, because the majority of people who screen positive are not an emergency. So now we have clinical pathways, suicide risk clinical pathways, that are guides to help us avoid these unnecessary interventions. These are examples of published clinical pathways. I don't expect you to read it, but I just want to show you they can be fleshed out and nuanced so that they fit the local milieu of where you're screening. But it boils down to these 3 steps. So it starts with a brief screen. That should take about 20 seconds with the ask. And then the most important part of the pathway is the brief suicide safety assessment. This takes about 10 to 15 minutes, and this is a further triage of the screen, right? So the screen is meant to identify someone who needs further evaluation. The assessment is what confirms the risk and guides the next step. This brief suicide safety assessment is meant to help the provider decide, what does the patient need next? Do they need a full mental health evaluation? Do they need an outpatient referral, or no further action is available, is necessary at this time? So there's 2 tools you can use for the brief suicide safety assessment, either the Columbia Suicide Severity Rating Scale, or we created a tool called the Ask Brief Suicide Safety Assessment, the BSSA. Now, no matter what tool you use, you should use that middle step to help the clinician identify next steps for the patient. Is this imminent risk? Or is this low risk and no further evaluation is needed at this time? Or the harder category is the one in yellow, further evaluation is needed. It's not an emergency, but you do need a full mental health evaluation. So the BSSA is not meant to be a full mental health evaluation, it's a safety assessment. Now, it's important that these tools and these pathways are culturally responsive, right? So I'm going to move into talk about some of our global work of validating the ask in a native language in the countries that speak them. So I want to talk about first our study in Argentina with doctors Rodante, Papavero, and DeRay, and they validated the ask in Spanish in Argentina. So the rates are high for youth suicide in Argentina, and not only for suicide, but for suicidal behavior and suicidal thoughts. You can see it's very similar to the youth risk behavior survey data that we see in the US. 20% of youth are thinking about killing themselves, 15% attempted. This was a multi-site study. 3 out of the 4 sites were medical sites, and 1 was a psychiatric unit. And what happened was that 301 patients were enrolled in the study, and you can see some of the demographics there. And then trained interviewers administered the ask, and then administered, blind to the ask result, administered a Spanish version of the suicidal ideation questionnaire as a gold standard. And then positive screens were treated as standard of care in that setting, given the safety precautions that were necessary and full psych evals, and the negative screens exited the study. And what they found was a very high rate of suicide risk, actually, and this, because this is a research study, there might have been some selection bias, and because there were psychiatric patients and medical patients together, so 27.6% of the patients screened positive. The majority, almost 90%, were non-acute, and they had 5 acute positives, so it was about 3% of the entire sample. And 20%, so that was with the ask, and then 20% were identified to be at risk through the Spanish version of the SIQ, the Suicidal Ideation Questionnaire. So the Spanish version of the ask had strong sensitivity, about 97%, that's the true positive rate, and really good specificity, which is the true negative rate, 90%, and that limits false positives. And also they were very aware that this is an Argentinian dialect of Spanish, and it could be different in different Spanish-speaking countries. We asked the kids, what do you think about screening for suicide risk in the medical setting? And the majority thought that nurses should screen youth for suicide risk in the hospital. Little less than half reported that they were comfortable or very comfortable. And 40% were neutral, so not as comfortable. 12% had some level of discomfort. So the Spanish version of the ASK, the Argentinian version, has been published and is available to be used. And we are using that Spanish version in some places in this country. But I also wanted to tell you about some other LMIC studies that we did. And we did, through funding from the American Academy of Pediatrics, we were able to partner with pediatricians in Nepal and Ethiopia. And so a hospital in Kathmandu, Nepal, validated the Nepali version of the ASK, much in that same way that the Argentinian study did. And now we have a Nepali version. And same thing in Ethiopia, in Addis Ababa, we validated the Amharic version of the ASK. And I just want to use this to show you that being culturally responsive was really important. So the ASK did not translate word for word. So for example, their fourth question is, have you ever tried to finish off or kill yourself? And because they told us the way to say that in Amharic was finish off. That is not something that we would have put in on an English version in America of the ASK, but that was an example. Another example was our Pakistani study, where the first question of the ASK is, have you wished you were dead? But wish in Urdu means something like a birthday wish. So that didn't make sense to patients, and we had to adjust that language as well. So the culture, validating tools and not just translating them is so important. So again, it's important to rely on this three-tiered pathway. And one of the things we saw is that you can do this 100 different ways, right? It's so important that it's culturally responsive. And when I say culturally, I mean the culture, but I also mean the local milieu of an emergency department, an inpatient medical surgical unit, an outpatient clinic. So it starts with the brief screen, then the most important step is the BSSA, and then that helps the clinician operationalize what are the next steps. And so it's different than just risk stratification of low, moderate, and high, right? Because the people in the low end of moderate and high end of moderate sometimes need different things. So this middle step of doing a brief suicide safety assessment helps you operationalize next steps. What does the patient need next? The American Academy of Pediatrics Bright Future has recommended suicide risk screening for all pediatric practices ages 12 and above. And along with the American Foundation for Suicide Prevention and some of us from NIMH, we created a blueprint for youth suicide prevention. It's available at the aap.org/suicide prevention website, and I encourage you all to look at it because it really helps providers understand how to embed suicide prevention in their medical settings. Now, a lot of the pushback on screening became, what am I going to do, especially in rural areas, if I don't have mental health access? What do we do? So we help the pediatric providers see that there's at least 3 things they can do immediately. And I'm sure this is being talked about at this conference: safety planning, lethal means safety counseling, and providing suicide helpline resources. And in the United States, that's 988, and that's different everywhere. But these are 3 things. And, you know, because kids who are thinking about suicide are thinking about it whether you screen them or not. And so we want to make sure there's interventions people have on hand that make screening worthwhile. So the ASK started in these 3 states. It's now being used nationally in many hospitals and outpatient clinics. It has been or being validated in these green pins countries, and then it's been translated into those languages in those countries in black. And I'll end here by saying, especially low middle income countries require evidence-based suicide risk screening tools because a lot of those youth are at higher risk, and then can be connected to life-saving interventions. The ASK demonstrated strong psychometric properties in the Spanish version, in the Argentinian Spanish version of the ASK, and it was acceptable to the majority of the youth. And it's really important that screening and the clinical pathways you use are flexible and adapted and implemented according to a culturally responsive manner of where you're using it. So nuance is really important. And I would love it if you had questions. I'm sorry I can't be there in person to answer, but please email me. Thank you for your time and attention.
Thank you very much, Dr. Horowitz, for the excellent presentation. This is extremely relevant for the countries in the Americas. We have increasing suicide mortality among adolescent groups in many countries. You have shared with us the importance of proactive screening in medical settings. As a consequence of that, you have also shown tools that can be used for that proactive screening, and you have finalized by showing us what can be done as a response to the identified needs, giving us important advice on effective interventions. Let's now move ahead, and it's my pleasure to introduce you to Dr. Richard McKeown. He is currently a senior advisor at the United States Substance Abuse and Mental Health Services Administration 988 and Crisis Office, after serving for 12 years as chief of the suicide prevention branch in the Center for Mental Health Services, where he oversaw all branch suicide prevention activities, including the Garrett Lee Smith State Tribal Youth Suicide Prevention and Campus Suicide Prevention Grant Programs, the Zero Suicide Initiative, the Suicide Prevention Resource Center, and the Native Connections Program. He served on the National Action Alliance for Suicide Prevention Task Force that revised the 2012 National Strategy for Suicide Prevention, and the U.S. Department of Health and Human Services Project Management Team coordinating the 2024 revision of the U.S. National Strategy for Suicide Prevention, recently released. In 2023, he was awarded the American Association for Suicidology Dublin Award for Lifetime Achievement in Suicide Prevention. So the floor is yours, Dr. McKeown.
Thank you very much. I'm so pleased to be here with colleagues from across the Americas to be exchanging information. And how do the slides get advanced? Just, okay, so you can keep it there. I was just, there we go, great. So as was just mentioned, the United States just released, we had a wonderful event at the White House about 2 months ago, releasing the 2024 United States National Strategy for Suicide Prevention. This is the third iteration of the National Strategy. The first was released in 2001, the second in 2012, and then this current one in 2024. The U.S. National Strategy is broken down into 4 strategic directions, of which I'll really be focusing mostly on one of them. But one is on community suicide prevention. There's been a lot of suicide prevention activity at the state level, but the question of how to get suicide prevention activities embedded in communities across the United States is the key component of Strategic Direction 1. Strategic Direction 2 is treatment and crisis services. And this is the first time that a U.S. national strategy has had a goal that focuses on crisis services. Strategic Direction 3 focuses on surveillance, quality improvement, and research. And Strategic Direction 4 is on health equity in suicide prevention. And I want to acknowledge, in talking about the U.S. national strategy, I was honored to be part of a team that included SAMHSA, CDC, and IMH, and the Office of the Assistant Secretary for Planning and Evaluation, who composed the project management team that did the work in collaboration with a host of private partners, the Suicide Prevention Resource Center and the Action Alliance, in order to achieve this revision of the U.S. national strategy. But I wanted to talk specifically about 988 before cycling back to its role in the national strategy. So 988 is a 3-digit national number for suicide prevention and other behavioral health crises. It's built on the foundation of the National Suicide Prevention Lifeline. First received funding for that in 2001 for that effort, but the Lifeline itself was launched in 2005. Many milestones along the way. In 2007, the Veterans Administration founded the Veterans Crisis Line, and we linked that to the U.S. national strategy. We have since added a disaster distress helpline, chat services, and then it was really in 2018 that the journey toward 988 started. And the FCC designated, and the National Suicide Hotline Designation Act was passed by Congress and signed into law by President Trump, which said that by July 8th, 2022, every cell phone, every landline, every voice over internet device in the US had to make 988 operational. So we are now getting close to 2 years into 988 being virtually universally available. We've really had two overarching goals and strategic objectives. Our assumption, which has proved to be very accurate, was that a 3-digit number was going to be easier to remember than the previous 10-digit number, which was 1-800-273-8255. In our report to the FCC, which they quoted in their report to Congress, it said that if somebody was experiencing severe chest pains, it was likely that despite that stress, the person and a family member who might be there would remember the number 911, but it was highly unlikely in a suicidal crisis that the number 1-800-273-8255 would immediately come to mind in the same way. So our first goal was really to expand the infrastructure so there was sufficient capacity to answer the calls, chats, and texts. Texts were also ordered to be, the capacity to text to 988 was also part of the order from the FCC. But we wanted to go beyond that. We wanted to use 988 as a catalyst for transforming behavioral health crisis services in America. In much the same way that over a half century, 911 was a catalyst for the development of emergency medical services. So our goal has been not only to strengthen and expand 988, but to transform our behavioral health crisis services with 988 as the center. The way we've talked about that is that every American should have access to someone to talk to through 988, someone to respond, a mobile crisis team that could come to you in many instances without the police, and a safe place for help, a community crisis stabilization program, so that people in crisis were not brought to jails or to overcrowded emergency rooms. This notion was built on what's called the Crisis Now model, developed by the National Action Alliance for Suicide Prevention, of a call center hub, mobile crisis, and crisis facilities. You may wonder what in the world is a picture of an airplane doing there. Well, for all those of you who flew here, an air traffic controller was always aware of where your plane was. But too often we lose track of people in the fragmented gaps in our crisis systems. So the idea of a call center, a hub, is being able to keep track of people in the system and make sure that they get connected to the care that they need. We've also worked, particularly in the first year following the release of 988, on expanding access through a number of different ways. We have had, going back to 2007, a Spanish language subnetwork where you could talk to somebody, a crisis counselor who was fluent in Spanish. We also have a language line that does interpreter services for about 150 different languages. But what we added more recently was Spanish text and chat services, where the, Spanish speakers in crisis can reach trained, culturally competent crisis counselors. So the way it works is that you call the 988. If you press 1, it goes to the Veterans Crisis Line. If you press 2, you hear the prompt in Spanish, it goes to the Spanish subnetwork. There is also now a prompt to press 3 for a subnetwork focusing on LGBTQI+ youth and young adults. If you don't press 1, 2, or 3, the call goes to one of over 200 local crisis centers across the country. There's at least one in every state. And actually, the state of Washington has instituted a press 4 option to be connected to a program called Native and Strong, which is a hotline completely staffed by American Indian crisis counselors. We also recently started an American Sign Language video phone service for people who are deaf or hard of hearing. So something that's of huge importance for us is that for 988 to be effective, people need to know it's there. There has been a significant increase in our contacts. We are now responding to about 10,000 contacts per day. And we have developed a wide range of materials for 988 communications. These are all things that can be downloaded from the SAMHSA website. And we have initiated a targeted communications effort, which are really designed to try to encourage and normalize help seeking, to build credibility and public trust in 988, and to encourage people to contact 988, both for themselves, but also for others, what we call third-party calls. Now, I mentioned before that, when we did the 2012 national strategy, we had no idea that there would be a 988. So in the current iteration that we just released of the national strategy, we did include a goal for the first time to improve the quality and accessibility of crisis care services across all communities. I won't read all of the objectives there to you, but you can see that there's a strong emphasis on collaboration, the public safety network with our 911 system, to reduce unnecessary police interventions for people who call either 988 or 911. Here are some of the other objectives. And you notice 9.4, when you look at the topic for this presentation around screening, assessment, management, follow-up, well, that's part of the objective there, is to increase timely access to assessment, intervention, lethal means safety counseling, and follow-up for people at risk of suicide across the entire crisis continuum, and to integrate substance use disorders into this, which was not focused on as much in the 2012 strategy. I want to close by adding that one of the things that was unique about the current U.S. national strategy is that for the first time, it was accompanied by a federal action plan. So federal agencies and departments combined to commit to over 200 actions to advance the national strategy. So these were things where federal agencies such as my own at SAMHSA and IMH, CDC, et cetera, the Veterans Affairs, Department of Defense, et cetera, all indicated actions that they would take to advance the U.S. national strategy. And I'll just give you a couple of examples of that. We said at SAMHSA we'd improve data collection and reporting on critical 988 data, including suicide attempts in progress. Every day, somebody who is making a suicide attempt in progress contacts 988. And in those situations, we obviously need to move quickly to get needed emergency medical services engaged. And then both voluntary and involuntary emergency interventions, and to evaluate the outcomes to support ongoing quality improvement. That SAMHSA would work with the Office of Emergency Medical Services, which is in our Department of Transportation, to develop guidance on when a behavioral health crisis requires 911 engagement versus 988 or 988 plus mobile crisis. That we would work with a range of partners at SAMHSA to increase the number of states that have established processes and protocols for review of 988 911 interactions, and to increase the number of 911 diversion programs to 988 centers. And then also last, from the Department, an example from the Department of Justice regarding their justice and mental health collaboration program. So that just gives you a flavor. There are over 200 action items of this sort, covering all 4 of the strategic directions that I indicated before. So I will stop there, but that gives you a very quick overview of what we've been doing with 988. And if you were not aware, that about a year later, Canada has also implemented 988. And we are with ongoing communication with the Public Health Agency of Canada and our Canadian colleagues to be able to share lessons learned there. And we are very interested in communicating with others across the Americas about your experience with the use of hotlines and what we can learn from you and what you may be able to learn from us. So thank you very much.
Thank you very much, Dr. Makion. I think you brought, again, very relevant and important topics for us, countries in the Americas. I'm sure that there are also colleagues from countries who are not present here who are following online. You shared with us the key strategic lines of the National Suicide Prevention Strategy recently released by the United States. You also helped us to have more information about 988, that it's universally available, and all the resources that are available, in fact, in the 988 webpage. It's really impressive, and I think it's very useful for countries who are starting the development of crisis lines, which is in fact happening in many countries nowadays. I just came back from one country 2 days ago where we are providing technical support to the country to create its first crisis line. The World Bank is providing financial support. So I'm sure that many of the things that have been developed in 988 can be very helpful. And I think you brought also another very important point on keeping track of people and connecting people to care. So thank you very much. Let's then continue. And it's my pleasure to introduce you to Dr. Pamela Espinosa Mendes, que é uma psiquiatra especializada em psiquiatria infantil e de la adolescência, com ampla
childhood
experiência em
psychiatrist
transtornos generalizados do
with great
desarrollo,
experience in
prevenção de suicídio,
generalized
formulação de políticas
development
públicas de saúde mental, además,
problems, and
de
she
enfoque
has
integral em terapia familiar.
a comprehensive approach to family therapy. Currently,
És a coordenadora de la
she
estratégia
is the coordinator of the National Strategy for Suicide Prevention in Mexico, where she develops and implements
de suicídio.
suicide prevention strategies. Previously, she was member of the team of EMPA,
Responsável de la gestión de investigación en servicios
responsible in the management of psychiatry
nacional
research and teacher at UNAM, University in Mexico. She provided psychiatric medical care in UNAM in Mexico, Clínica Divergen, and she worked as research help assistant in the CONACYT in Mexico. Go ahead, Dr. Espinosa, the floor is yours. Good morning, I hope you're all okay. It's a pleasure to be here. We are excited in presenting the adventure of the National Strategy for Suicide Prevention in Mexico, where PAHO was involved at all stages. First of all, I thank you for the invitation. And we are already establishing synergies. All that I'm going to tell you, I hope that it will help you to establish synergies. The first slides show suicide and suicide behavior outlook in Mexico, but I want to go to implementation. As you can see, and what was mentioned in all presentations, there has been an increase in my country in hanging, suicide by hanging, strangling, or choking. This is most of the suicidal behavior in Mexico. In Mexico, we are working on the rate of suicide between the people between 25 and 39 years of age. And currently, Yucatan, Nayarit, Chihuahua, other states where there's apparently greater number of suicidal behavior cases. What we are expected to raise awareness about all these situations, so we are awaiting that. Mérida has worked a lot in the area of suicidal behaviors. It's a state that is in the first places, but it should be added that it's a state where reports, address the situation. We are working with attorneys' offices and raising awareness of doctors. I don't know if you have the same issue, but there's a daily report, and then there's a report of self-damage leading to a report, but at some point yesterday, in different presentations, it was mentioned that oftentimes there was a certain trepidation to issue a report, given certain situations and the insurers also. So we have to work to raise awareness of this. These are part of the self-inflicted damage. I will delve into more detail later, and we have a record of self-damage, and that's important. What happens with the National Suicide Prevention Program in Mexico? It is an interesting program. First of all, let's talk about research. I want you to realize how coordinating and working with researchers and all institutions and centers helped us to bring this about. At some point, Dr. Malo, we thank him, together with Dr. Paulina Arenas and teacher Diana, they were talking about suicide, about suicidal behaviors. And something has to be done in that respect in Mexico. And so PAHO supported the implementation of a workshop of mini Congress for all researchers and all key actors in Mexico with regard to suicidal behaviors. We made sure that they attended that and they started working. All of this work was initiated We have already a national workshop that leads to the National Suicide Prevention Program. But this needs governance, as we saw yesterday, and so we saw that we need to work in the governance area, and Dr. Quijada, Dr. Eva, everybody started reforming the Mental Health Act in my country, a reform that included suicidal behaviors. And we were also implementing MHGAP. So there was an awareness raising in Mexico with MHGAP and mental health. And at the same time, and then there was already the National Strategy for the Addiction Prevention, or EMPA, and that led to the national program. And we also had a reconversion at the second hospital level, where, it was said yesterday, the best evidence is don't hospitalize a patient regarding suicidal behavior, depending clearly on the risk level. But we were raising the awareness of the whole hospital system and the area of mental health. We realized that there were integrated health services networks, the so-called RIS. Without an RIS, there's nothing. So we started coordinating all units, care centers, starting from the individual and the community. So we integrated all actors in the ideal world. And this led to Modoris. That's also why we're here. We started working with researchers. The Mexican health system needed to mainstream suicidal behaviors. So my colleagues started to work in what we now call Modoris, which is a dynamic model of risk orders. With regard to care, it structures care depending on the risk level, where each actor knows what to do. If you're a social worker, your work gets so far. As I said yesterday, for example, sometimes a teacher seems exceeded by what he has to do. No, your commitment is up to that, and it stays in that. So each had his or her own function, and this model trains the small integrated networks called RISs. So to start forming a so-called mini city in this suicidal behavior component, where all the health system and all the system has to intervene in an ideal world. Now also in this system there's a referral part, because oftentimes what happened was that the patient got lost in this world of referrals and he was not given follow-up. We had already prevented suicide. He's here, but what happens with giving sense to that life? That's a very important goal. This led to PRONAPS, National Program for Suicide Prevention, that currently has 5 axes: coordination, surveillance, interventions, training, and research. PAHO was hand in hand with us in all the 5 axes, advising, and they also worked with Dr. Quijada. So, and they addressed governance. What happens with our axis? We have the training axis. The training axis got PAHO's support at the beginning, and this helped us to assemble the program. This training is online, And we started training specialized and non-specialized staff at all care and attention levels, and this is totally open. But demand rose, and at that point, the Secretariat assumed the course, and now there's a continuing training online under the aegis of the Health Secretariat in Mexico. We have already more than 57,000 registered people and more than 29,000 trained people. Now, what are we going to do with trained people? We started mapping this to identify each person and make that person available in a directory, and so a person, a suicide-prone person, could consult that register and request the assistance of that person, well, because there are parts without access, so we needed to map this to identify the available resources. Then, within the training, there's the media. We are working on this. There are national weeks. This national week, our guest will be the metro system of Mexico City. And from the metro, we will start another training with the media. And here we establish synergies, but because as I said yesterday to my colleagues, this is an open workshop. People from other countries may connect online to the workshop. The workshop will be on the PRONAPS webpage, and it is totally free of charge. It will be a 2 or 3 day workshop. In vulnerable groups, we are working in the area of social readaptation. We are giving support in guidance implementation. That's the point right now. So this is a very young program, because if you look at this, this started with a workshop in 2019, and implementation started only in 2020. So this is a very young program. What happens with the interventions axis here? We have the suicide prevention strategies for undergraduate doctors and social service interns. We work with what we have, and in a very rough manner with few resources. We are working on this because money is very important. We need funding, and in this situation, we started at different scales. And after regular time, these doctors are screened and are assigned to a certain level. When there's a moderate to high risk, we give monitoring and follow-up, and they enter, these potential patients enter into the subsystem. We had the idea to download the strategy to education staff, because in that way we can provide care and to detect people at risk, because we are working in the education area. That strategy is the responsibility of another colleague. So far, we have done 53,744 interventions, of which about 8%, an annual average of people identified as of middle to high risk. Everything has been downloaded. There's a roadmap that has been downloaded, and if you open the Pandora's box, is how you will provide care. That's why right now we are only working with undergraduate doctors and social service interns, and we will expand this later on to a larger number of health service people. If we open the Pandora's box, who will take care of these individuals? This strategy will be developed with the National Genomics Institute. We are waiting for that institute to accept one of our projects, and we will start to establish genetic biomarkers. Coordination, that's very important. And we also have support lines. Here we have the lifeline and community brigades, groups that go to communities and they provide detection and care services. These brigades are also mapped, and they are constantly being trained. Then there's the case management. Here we guide each key actor as to how he or she has to act vis-a-vis suicidal behavior, not to abandon the system. We have a Code 100 covering suicidal behaviors and where each hospital actor at all levels has to act, depending on the risk level. We have already implemented 60% of training at the country level. Within the surveillance axis, we have an information system, and we have already been able to mainstream suicidal behaviors and indicators in the daily reports, and through RENASPE, all suicidal behaviors in my country is reported. What happens with research at all these axes? In research, we see what you see here in the screen, and we work with the National Public Health National Institute, the National Genomics Institute, and the National Pediatrics Institute on different strategies when it comes to suicidal behaviors. And there are also civil associations. When you knock on doors, you realize that there are different hotlines and everything is there. And so this implements the networks. We have commemorative weeks. And I would like to show a video. This is the team, a team of really young people. And it has been a very good team. I will invite you to watch this video that summarizes what is the National Suicide Prevention Program in Mexico.
El Programa Nacional para la Prevención del Suicidio, PRONAPS,
The
ha implementado
National
una serie de estrategias
Suicide Prevention Project has implemented strategies to address the gaps in suicidal behaviors, especially the initiative for specialized training that gives professional essential tools for prevention, early risk detection, assessment, and effective prevention in the case of suicidal behavior. And we have indicators and a systematic registration about risk. Training programs have also been covering the jail and education sectors, including postvention and suicide prevention in academic environments. This focus complements with efforts to raise the awareness of the general public, including cultural and sports initiatives such as the race in the framework of the National Suicide Prevention Week in September. In the framework of the World Suicide Prevention Day, we address the general population and the health teams to provide knowledge and tools to prevent suicide. They care with by community brigades are examples of how this is implemented. We also work in the Code 100 in case management that supports the care for suicidal care at all levels of attention. The expansion of specialized psychiatry services for children and adolescents and other programs for the protection of families and the training of psychotherapy of evidence-based psychiatry professionals through PRONAPS that makes it possible to have healthier societies and to continue training programs to solve stigmas, myths, and prejudices, to promote resilient communities with the support of the General Health Act in Mexico and the support of prestigious academic organizations and international organizations. The program is implemented, but there's the challenge of adjusting periodically these strategies to take into account intersectoral factors on behalf of healthy communities.
Thank you very much, Dr. Espinosa. You have shown us the increasing rates of suicide in Mexico. You have also shared with us the important role that played the review of the national mental health law and all the advances on the integration of mental health into primary health care that Mexico has done over the last years. And on top of that, all the work that the country has been doing in the establishment of networks of care, creations of health centers, flows, also protocols, and a very strong community-based work and awareness. And I was very glad to see many of my PAHO colleagues in many of the photos that you showed us. Thank you very much. Let me just ask my colleagues if Paulina was able to connect.
I'm here. Can you hear me?
Oh, yes, and it's great to hear you, Paulina. And I was just about to introduce you. Lo más importante es que Paulina es una amiga.
The most important thing is that Paulina is a friend, and she has a very important story to share with you. Paulina del Rio lost her eldest son to suicide in 2005 when he was only 20 years old. A couple of years later, she started to write in blogs where young people were looking for suicide methods by listening with empathy and without judgment. Then she trained as a gatekeeper and later as gatekeeper trainer. In 2014, with her niece, she created the José Ignacio Foundation that offers workshops, classes, and discussions about prevention and postvention. For 10 years, she accompanied people who were considering committing suicide, and for 5 years, she has supported mutual help groups for people impacted by suicide, and she trained other facilitators. She also participates in the design and the execution of postvention programs for schools, universities, and companies, mainly in Chile. In 2019, she obtained in Chile the Mujer Impacta Prize for her work with people who suffer. She also worked as a commissioner of the high-level PAHO Commission on mental health and COVID-19 in 2022 and 2023. Thank you very much, Paulina, for being again here with us. The floor is yours. Go ahead, please. Please, I need to share my screen. Thank you, Paulina. We are working on that.
¿Está bien?
Pero está resultando, lo siento. A ver,
I don't see my screen. I have had so many technical problems. I'm really stressed out. Don't worry, we will wait for you. Yeah, now, okay. So, first of all, my greetings. Paulina, please, in presentation mode. Thank you. Perfect. Thank you very much. My greetings to all, because from Miami, I should have been able to fly to Washington for today. That was not possible, but with the same excitement, I will present the approach of someone who is not a researcher. I am neither a policymaker nor a researcher, but I have been working for many, many years, especially to talk today about postvention on a community basis, address the pain of death by suicide, acceptance and healing from those who survive, the relatives of someone who committed suicide. This kind of pain cannot be managed by oneself. It needs a tribe. As always, I start with Jose Ignacio here with me in my heart, because he's no longer with us. And very quickly, the process of mourning is not a pathology in itself. Most people can solve their mourning if supported by other people who give them support, understanding, and love. It's mourning is adaptive, natural, and biopsychosocial. There's no correct, quote-unquote, way to mourn. Mourning is not the same for everybody. In a couple, for example, one of the members can have one type of mourning, the other one another type of mourning. Everything is correct and permitted. This is not linear, because people think that there are setbacks, but no, you have to repeat that. You have to go backward to then move forward again, so there's no failure. The intensity and duration of mourning depends on different factors, the characteristic biological and psychological characteristic of a person, the circumstances in which suicide happened, and the personal history, of course.
We believe that mourning and grief because of suicide is much more complex, that the emotions are very intense, a lot of loneliness, because people tend to separate, to go away from society. They don't know what to do. It is not because of a bad will, because they don't know what to do. The guilt is really heavy, and then you wonder, why? Why was I not there with this person? Why didn't I talk to him about it? Why did I believe that he was simply wishing to draw attention? And the other question that haunts us, what if I had done this? What if I had obtained a better treatment for him? What if I had not left him on his own and alone at that time? Everything that haunts us for a long time, until each one of us starts stopping with all these questions. We also believe that the dead person did not want to continue living, as if this is something that has to do with your own volition, and a great sense of failure for the parents. For example, we did not look after him. We did not do our duty as a parent. The social stigma that still exists, it is still considered to be a taboo. People are afraid of contagion, as if suicide were contagious. People, from what I remember, they saw someone who looked alike. He walked by the street, walking towards me, and crossed the street, simply crossed the street, because obviously they didn't know what to do. They didn't know how to handle this. And to understand that suicide is always traumatic. Even if the person had gone through 20 suicide attempts before that, it will still be traumatic, and it will bring with it psychological, emotional, and physical impacts that are always brought by trauma. And amongst the survivors, because of a loss caused by suicide, that there's a greater risk of suicide behavior. I know that I brought to you one of the worst examples because South Korea is one of the countries in the world with the highest suicide rate, but it was the most recent information that I had. 3 times more deaths caused by suicide amongst the survivors than within the general population. Then, one of the ways of being with the survivors and support the survivors is with mutual aid, mutual assistance groups. And so what do you find there? The survivor internalizes and he sees that he's not the only one who's been through this. In the group, he's better understood. He's not judged. He's embraced. Mutual support because one helps the other one and there's mutual help. Those who are just starting, who are just beginning, see in those who've been there longer that you can be better, and those who've been there longer see in the new arrivals how they arrived. They see themselves in how they were when they arrived, and they see themselves as a reflection. And the group provides you encouragement, and they share tools that they have used in order to face these difficulties that many times are unique for this. They give you comfort. They build ties in a significant and solidary partnership. It lowers loneliness, obviously. We have a WhatsApp group 24/7 where people get connected and where the facilitator supervises at least once a day to see whether anyone is going through problems or whether there is a mistaken concept that has to be corrected. I brought you a couple of testimonies from the current group that we have. In the group, I feel contained. I'm very grateful for that unity, the understanding, empathy, and for people listening to me. This is what we all need, to be heard, not to be tried, not to be given advice, only to understand. And I will read another testimony. The fact that we belong to this group, each one of us are working on their grief, on their mourning process, is an outstanding support, sharing the experiences, listening, and little by little healing. We have the feedback, and it helps all of us. So what is the experience model that we've installed in the Jose Ignacio Foundation, which has been the result of both existing models as well as of our experience, particularly mine, because I've been there for longer? Is it an open forum? We don't have a deadline. There are no requirements for insistence or assistance. There are no predetermined issues. People get connected what they want and when they're able to do it, to meetings that are held every 2 weeks. And we talk about what has happened in the course of those previous 2 weeks. Or they talk about what they're afraid is coming for the future 2 weeks and other things that come up. It is a protected model where there is confidentiality, where people deal each other with compassion, where the facilitators can detect and act when they see mental health problems or a complex mourning process or a suicide ideation, particularly a suicide ideation. And obviously this is referred to the private or public network. Facilitators are volunteers. They're not remunerated, and they're experts because of their experience. And they are given tools in order to learn how to listen, to empathize, to validate, to hug, to embrace, and not to judge. Hopefully, people could learn about these 5 concepts by heart: to hear, to empathize, to validate, to embrace, and not to judge. And it is aimed at the achievement of acceptance of a new life, a good life, okay? Because you imbue confidence, letting people know that the future will be different, but not necessarily worse, and that it will be in the company of the beloved person, but in a different place, in your heart, not in the physical presence. We lost the sound. We apologize, but we lost our sound.
Solamente un minuto, Paulina. Tenemos un problema con...
Give us a minute because we have a problem with the audio here. Let me see, it's back. Please continue. Please continue. We can hear you now. What does a survivor in the group learn when they learn to accept the consequences? To replace, to find a new place for the person who is no longer with us. I place him somewhere else, but he continues to be with me. The pain and the guilt will be overcome, and that memory of that person, the beloved person, is working so that the mourning can be solved and you can go back to life, making contributions to life, to see a future because they have to develop strengths and strategies. And this, to have self-compassion when faced with the difficulties. We always say one has more compassion for a dog that is hurt, that is wounded on the street, than with yourself. And that is something that you learn in my group, how to participate in a support network, knowing that you can be in permanent communication. It doesn't matter how long you've been there without participating in the group, that you're going to find help and assistance at any time, because this is the idea. And this perhaps is the most important thing, to go from survivor to someone who lives with a sense, that is to say, you give sense to the death of the person who passed away and to our life that's coming. So they have to play an active role in the process. There's an author known as William Warren, and he talks a lot about this, that the process is work, ongoing work, and that is good because people feel that they have something to do, that they're not simply there and others will tell you what to do. So as I was saying, we need to give a meaning sense to this death and to this new life. And I will show you some of our achievements because I'm also very proud of that. We have been here for 14 years offering free in-person groups until 2019. They were in person until 2019 and online since 2020. We have people from several countries. We have meetings every 2 weeks. We offer 2-hour meetings and a permanent WhatsApp group. And we have over 600 survivors who've been through the groups and who've come. For example, currently we have people from Colombia, from Guatemala. We've had people from Argentina, from the US, Spanish-speaking people. So I believe that we will continue with this online modality because otherwise these people would be left out, just like the people from Chile who don't live in Santiago. We've been taking care of this since 2022, and we've provided psychological assistance for free to 36 survivors that had some serious mental health problem or risk of committing suicide. And we hope to provide that assistance to many more, but that will depend on the following slide, which is this one. We, as survivors, what do we need from our government? Well, we need them to reduce the stigma, maybe bring it down to zero with campaigns, with information all over the place in order to reduce the prejudice, to promote empathy, difficult task. We need them to train the people who would be in contact with the survivors, such as health personnel or people who work in education, the communities, such as, for example, churches, sports club, etc., the family, obviously. And obviously, we need the government to provide funding, because otherwise, if we don't have sustainable resources, not only for community initiatives, but also state initiatives that are so important, otherwise we can't do anything. We do what we can with the very scarce funds that we ourselves obtain but we need something on a permanent basis. Coordination, as the doctor from Mexico was saying. Articulation, articulation, articulation. To articulate the efforts amongst all stakeholders, all institutions, public and private institutions, to allow a much better identification of people at risk, in this case survivors, and to know where they are, to be able to contact them through health services, through religious services, for example, and to be able to refer to mutual assistance groups, to health networks, etc. And we don't get anything if the policies are wonderful, but they don't get to us. So also governments would have to ensure that services will reach the entire community. Regrettably, nowadays, that is not so much operational. It is not working that well because we're focused on prevention. But I know that at least in Chile, the plan is also to focus on postvention. And before I bid you farewell, I will stop sharing and
No, está bien.
that's okay. Yep, that's okay. Let me just address some words from myself, from someone who lost a beloved person because of suicide, those who lost someone dear to us because of suicide. We don't need advice, we don't need counsel, we need hugs and embraces, we don't need judgment, we need respect. We also need for people to be patient with us because mourning is a long and painful process with a Russian mountain, with ups and downs, with emotions. In one day, you can have 10 different emotions. When we lose someone who's dear to us because of suicide, one day we look out the window and we don't understand how the world continues to go on. We would like everything to come to a halt, to stop, for people to know that our arms hurt because we can no longer hug and embrace the person who's gone. Hopefully they can understand that when we go to work, we have to scream and to cry somewhere. And it is not because we're lazy, as we say in Chile. It's not because we're getting to be lazy, but because of our soul hurts. Don't forget that we are active and that someone who's beloved to us are not only statistics. That is all. Thank you.
Thank you so much, Paulina. Thanks for really reminding us why we are here. And congratulations for all the work that you have been doing. Thank you so much.
Thank you so much. Thank you, Renata.
Colleagues, we have time for perhaps 2 questions or comments before going to the break. So if anyone wants to question or comment on something, please just raise your hand. Belén, por favor.
Bien, tengo dos preguntas.
I have 2 questions. First, Paulina, I would imagine that you're still connected. Are you still connected? Yes, Paulina. Dear Paulina, as always, it's a pleasure to hear you and to see that Paulina is a wonderful cooperator for us in Chile. We've been fortunate enough to work with her shoulder to shoulder. He's supported us in the development of a document that we prepared for survivors in order to support the community. Extraordinary expert, and we're very fortunate to have her in Chile. But Paulina, my question is how to involve even more people with experience in suicide advocacy, but also in the development of public policies and also research, because we know also that we're fortunate enough to have people like you who can support us, and also lucky enough to have other foundations. But we need more participation, particularly to have policies that are sensitive and that will respect the experience. And as you have pointed out, that we don't see this phenomenon, that we don't get lost among the figures and the budget and everything else, that we don't lose our humanity. So first of all, we wanted to ask Paulina that. And I have another question for Dr. McKeon regarding whether you've looked into the line of assistance for artificial intelligence, whether you've looked into artificial intelligence, any opinion about AI or chatbots or for suicide prevention, and what do you think about that? Thank you. Paulina, if you can answer in 1 minute, please. Thank you, Belen, for your compliments. It seems to me that our group has several people already that have experience, that have spent several years in mourning, and that possess a wealth of wisdom. So I believe that this form of articulation is extraordinary, and we can find out in this group or in other groups, because the people, the survivors, the only thing they want is to cooperate, to collaborate.
Muchas gracias, Paulina.
Thank you very much, Paulina. Dr. McKeon.
Thank you for that question. We're certainly giving a lot of thought to the issue of artificial intelligence and how that can apply to our work, both as a federal agency, but also as a network of over 200 crisis centers. I'd say the way that it's being used mostly now by some of the crisis centers who are part of our network has been in the area of supervision. And by doing things like, so for example, the Lifeline has a requirement that each of our centers has to review 3% of their contacts for quality improvement processes. That's very time consuming, and you only get to 3% when you do that. Artificial intelligence offers the possibility, particularly for things like chat and text, but also some of our centers record their calls, others don't, but artificial intelligence can be used to analyze them in a way to be able to provide that information to a supervisor to go to be able to discuss with a crisis counselor. I know that the U.S. Veterans Administration has been looking into this, as well as the use of machine learning. As part of the U.S. military, the White House's military and veterans suicide prevention strategy was to look at the applications of machine learning in the veterans crisis line. So that is something they are currently looking at. But would love to talk further because I think it's something that we are all learning about and understanding what the potential uses might be. One thing that we are concerned about and would not be looking at would be using some of this kind of technology for actually responding to people. You know, we want people to know they're talking to or texting with or chatting with a live counselor, not with a bot.
Thank you very much, Dr. Marco. There is space for one more question. Creo que Dr. Ordóñez. Sí, por favor, doctor.
Muchas gracias.
Thank you very much.
A la compañera de México.
To our colleague from Mexico. In my country, there's a major concern about the increase in suicide rates in health personnel, and I'd like to hear about your experience. First, I'd like to know what the process was like, the awareness of raising in health professionals regarding being assessed about the suicide risks. And then, why we have not gone beyond the capacity to respond by the institutions themselves. I would believe that there's a gap in human talent, or at least in my country, there's a gap in human talent on who take care of these people, worry about the external use and not the internal use, and to be able to work with them both. It becomes quite complex. Thank you very much, Doctor. In connection with awareness raising, we've been working on absolutely all levels of care, everything that has to do with the suicide prevention. And I go back to the same. I was telling you yesterday in one of the talks, it was almost indication You have to do this part, and many physicians, yes, in fact, because of the fear of something will come out, I have a depression or anxiety, and then I will be kicked away from the social service, the residence, or the internship, and that's where you have awareness raising in that place. So we go to that place and we raise awareness so that we can overcome that part. In connection with the care, that's where we bring in all the different taxes because there will be an overflow. And then we have brigades at the community side of it. They're given a kit. They go to the talks, and it has to do with the care and the attention that is given and the follow-up. So what we're doing is that people, community, hospital, when they attempt to come in so that there won't be an overflow of systems in connection with the health personnel, which has supported us so far. Thank you very much, Dr. Espinosa.
For the break, we are gonna change a bit the schedule. So if we can come back here at 15 past 11, we can start the panel 6. The coffee and refreshments are being served this time at this floor, and I hope you join us there. Thank you very much again. Thank you, Paulina, for being with us. Perhaps a round of applause again for the panelists.
for, unfortunately, we have only one panelist here in the room with us. We have two of them joining us live. We wanted to kick off the last panel around research. So as all of you are aware, research in suicide prevention is essential for bridging knowledge gaps and advancing implementation strategies, effective practices, and connecting them to public policies. Our next panel, assembled here and virtually, will have distinguished experts who have pioneered innovative community-engaged approaches to reduce suicide risk among some of the most vulnerable communities across the world. This discussion will explore research methods and public health strategies and tackle social drivers of suicide risk. Panelists will also spotlight community-based and intersectoral approaches, offering insights on strategy, feasibility, acceptability, and sustainability of interventions for suicide prevention in diverse settings. So with that, I'll hand off the first to our panelist who's here with us, Diane Machado. Diane Machado is a renowned psychologist with a master's and PhD in population health as a principal investigator of an NIH R01 project and an affiliate of Harvard Medical School and the Center for Data and Knowledge Integration for Health from Brazil. Diane's research is pivotal in understanding the intersections of economic interventions and mental health and leverages extensive data from over 130 million Brazilians to reveal how cash transfer programs can mitigate suicide risk. Her contributions provide robust scientific evidence for intersectoral approaches and integrate financial protection with mental health strategies to enhance global mental well-being and suicide prevention. Take it away, Diane.
Hi, everyone. Thank you for taking the time to watch my presentation today. I will talk about cash transfers, but also about use of data to produce research. And I will start by saying that in this very moment, billions and billions of data are being produced around the world. And we have two choices, either ignore it or use it to produce knowledge, to base our decisions in evidence. This data, it can be systematized in two ways, into aggregated ecological level data and individual level. For the aggregated, we could say the municipalities, state, countries, you can aggregate them and compare them and find the answers. And you can use the individual level data, which we have been largely using with this over 130 million cohort in Brazil. So now I will walk you through what we have been doing in Brazil for the last decade, last 10 years. And for this first study, we tried to understand if income inequality was associated with suicide in Brazil. And we found that municipalities with higher income inequality also had higher suicide rates. Municipalities with better income, higher income, had lower suicide rates. And we also observed that the change over time, if you see more in the south of the map, where the inequality was decreasing, income inequality was decreasing, the suicide rates were decreasing as well. Although in general, suicide is increasing in Brazil as it is increasing here in the region of the Americas. One thing interesting about this study is that when I was doing my literature review, the previous studies published, also investigating income inequality, did not find association. But these studies were done mostly in Europe, in the European region, and in high-income countries. So if we only use these results to base our guidelines and our advocacy, we would say that maybe income inequality is not important. But later, even here in the USA, another study was published here, and they also found association. Just saying that to highlight the importance of using data and doing research in our area to actually prevent suicide, to actually know what's happening to us here, which might be different from what is happening in Europe and in other regions. So for the second study, this study was during my master's actually, we try to understand which are the most risky factors for suicide, which are the people who are most affected. We found that the most affected are the least educated in Brazil, and also the First Nations, the indigenous people with over 200% higher chances of dying by suicide in the country. The main causes were hanging, gunshot, and self-intoxication by pesticide. And we also observed that the highest percentage of growth was allocated in the Northeast, which is the poorest region of the country. We updated this study with the current grant that we won, and we found that still the First Nations are the most affected by suicide in Brazil, so it's a big problem in the country. And we are still seeing these rising trends following the Americas trend, unfortunately. Our question later was, okay, suicide has been associated with economic factors. Would the community mental health services be able to prevent those deaths? And we evaluated that also at the aggregated level, and we did not find association between CAPS coverage, which is the Brazilian Community Mental Health Services, with decreased suicide. But we did find an acceleration in the already rising trend during the austerity policies in Brazil that was adopted in 2014. And one of the explanations for this is the link between poverty and poor mental health. This paper here, published by Matthew Ridley, he proves a causal mechanism where he explains poverty increases worry, physical health conditions, early life conditions, it increases risk for violence, crime, and decrease the social status. And all of that impact on mental health increase the risk of mood and anxiety disorders, while mood and anxiety disorders also impact on productivity, women empowerment, labor supply, preferences and beliefs, and economic decision making. And all of that, again, increases the risk of poverty. So what I'm saying here is that we are stuck in a cycle, and the question is how to break the cycle. In 2004, Brazil launched the Brazilian Cash Transfer Program, Bolsa Família program. And this program aims to intervene at the poorer and the extreme poor families in Brazil. The focus are mainly on women and children. And this program, there are two types of programs, conditional and unconditional. This one is conditional. So for the family, keep receiving the money. The pregnant woman has to attend all the medical consultations. If you have a children in the family, your children must be continuing going to school. It has to attend up to 75% if it's a child, or 85% if he is an adolescent. And this program, the research before mine has been showing that this program has helped to promote social inclusion, and it has strengthened human capital among the poorest, and it has decreased poverty and inequalities in Brazil, and it also increased the school attendance. And all of that is associated with factors that increase the chances of, all of this is associated with mental health and suicide. So if we decrease poverty and inequality, we would expect an impact on those outcomes. There are several studies before showing the impact of the cash transfer on physical health, such as decreasing tuberculosis, leprosy, child mortality. And our next question was, would the cash transfer their impact on suicide? So we first used the first one that I explained to you, the aggregate level study. We first used this design, and we found association between increased coverage in the municipalities with lower rates of suicide in those municipalities. And the next question is, okay, but does cash transfer prevent suicide at the individual level as well? To do so, we had to put it together this over 130 million cohort. And to do that, we linked data, used the whole hospitalization data in Brazil, the whole mortality data, the whole violence data, and we linked that with the Cadastro Único, which is the system where everyone who is applying for any type of benefit in Brazil goes through. And we basically have more than half of the population in Brazil in this register. And by doing so, we are able to rebuild the history of the families. For example, here, Maria, let's say Maria joined the Cadastro Único in 2001. In 2005, she got married to João. 2007, they had Pedro. 2007, João was killed. He was a homicide victim. 2007, I found Maria in the hospitalization data, and she was hospitalized by a psychiatric disorder. In 2015, she tried or even died by suicide. So we put it together, all this huge data set to build this powerful tool where we can answer questions in research. So in sum, imagine that the population of Brazil currently is 2015, but during this study was 2011 million people. We have over half. And then from there, we can identify who received the cash transfer and who did not. And then we compare among those who received, how many died, what were the rates, what the risk that died by suicide or not, and what the risks are, and then also among those who did not receive the cash transfer. And all of that during a long period of time. So for this, our first publication, we found that people who did not receive the cash transfer, non-beneficiaries, had twice higher rates of suicide compared to those who received the cash transfer. And we run several statistical analyses, robust analyses, and every single one, we found a strong effect of receiving Bolsa Familia and decreased suicide rates, with our final model showing 56% decrease in the suicide rates in Brazil, in the country. We also did analysis breaking by subgroups. For example, female, we found higher effects among females and also among people 25 to 59 years old. Currently, with our grant, we also evaluate among race, and I didn't bring because it was published and because of time, but we have found a higher effect among Black people, especially among women, Black women. And hopefully it will be published by the next conference, and I can bring this up. But then why? What are the mechanisms that actually link cash transfer with reduced suicide? So we applied for this grant that we're very lucky to win. And now we are testing if giving money to people reduce the parent mental illness, decrease the mental illness of the person as well, and therefore decrease the suicide risk. It's because giving money to these families reduces the exposure to violence and therefore decrease mental illness and suicide, or is because giving money, transferring the cash, it decreases impulsivity, and we are measuring by hospitalization for injuries, and to see this actually reduce suicide attempt and also suicide cases. And why this is important? This is important because it has high potential for population impact, and it also decreases the costs in mental health facilities. And I explain you why. For example, in this first pyramid here, Maslow, he proposes that we needed to have our physiological needs matched: food, water, warm, rest. And so we can then progress to the next level, which is safety needs, like security, safety. So what he argues is that we need to have our basic needs matched, and then we can move to the psychological needs. I'm aware that there are more updated theories nowadays, but my point here is that these programs are intervening at the basic needs. And it brings high potential for population impact. If you see this second pyramid here, you can see the framework for public health, that if we intervene in the socioeconomic factors, we increase the population impact. While when you go to the more specific, specialized, like clinical intervention, counseling, it increases the individual effort needed. And moving to the third pyramid, the optimal mix of services by WHO, they also argue that interventions at the community level, it increases the impact and decreases the cost. As we know that long-stay facilities, specialized services are very expensive and just not enough around the world. And I would also add that here what we should think is of how to prevent people to get severe and then move to the next level and then overwhelm the facilities that are already very overwhelmed. So we have been discussing here about the prevention, but I think we should also bring to the table promotion, how to do promotion, how to prevent people from get even ill when then we need to treat them. So these programs have been spreading all over the world, but I would say it's just not enough. We should aim for more. And we should aim for more because the number of people experiencing hunger has been increasing since 2015. And with a significant acceleration in 2001, due to the impact of pandemic and conflicts, most people with mental disorders and people in risk of suicide do not have access to mental health care. If we see even depression, only 23% get assistance in high-income countries. In low-middle-income countries, it decreased to 3%. Most services are overwhelmed, as I mentioned before, and finally, no other intervention has shown such a strong effect on suicide up to now. So I would like to leave with some final remarks. I hope I didn't pass too much time. So I would like to say that ending poverty would likely alleviate the strength on scarce resources for mental health treatment. It could have an impact on reducing suicide rates. And these programs, they have power of impact on people, on services. It can decrease costs and result in lower rates of suicide. And you might be thinking that this is a low-middle-income country problem, so it doesn't, there is nothing to do with high-income countries, but actually I argue that not. It has to do with the whole world. If we think of technology and automation of many jobs that are happening right now, we can expect an increase in job loss and income as well. And in fact, we will also see a concentration of money, and we're gonna leave millions and millions behind. Additionally, factors such as conflict, as wars, as we have seen recently, disasters resulting from climate change and disease outbreak, as we saw with COVID. So I would say that more than ever, an intersectoral approach, including financial protection, will be imperative to enhance global mental health and prevent suicide. Thank you. And thank you for my funders as well, and Renato for the invitation.
Thanks, Diane. That was fantastic. One quick summary about the cash transfer program and the last point you made about persistent poverty. At the NIH, there are a lot of institutes which actually are thinking about addressing persistent poverty, not just in low and middle income countries, but in high income countries, and especially within the domestic setting, to think about its impact on both physical health needs, cancer, cardiovascular diseases, and mental health as well. So I just wanted to flag that that's very well within the radar of NIH. So thank you for the wonderful presentation. We next have Dr. Lisa Wexler. Do you mind turning? No, your microphone. It just echoes. Dr. Lisa Wexler is a distinguished professor at the University of Michigan School of Social Work and a leading researcher at the Research Center for Group Dynamics. With decades of collaborative work alongside Alaska Native communities, she has been at the forefront of promoting mental wellness and suicide prevention through strength-based participatory research. Dr. Wexler's innovative approaches translates research into actionable community solutions, addressing real-world challenges. She currently spearheads 3 major federally funded studies, one on a brief intervention to reduce firearm access through family partnerships, the evaluation of PC Cares, a community-driven suicide prevention initiative, and the Alaska Native Community Resilience Study, which is a mixed methods exploration of community strengths in reducing suicidal behavior. With that, Lisa, please take it away.
Hi, thank you for that great introduction, and I am so happy to be here. I'm going to share my screen, I do believe. Let's see. I know you all have been hearing so many amazing presentations. I am going to try amazingly hard to stay within my 15 minutes and to share enough with you to generate questions or thoughts. So I wanted to start, I'm going to talk about the middle.
Lisa, we are not able to see your slides yet, if you don't.
Okay, let's see. I am sharing my screen according to my view. Let's see if I can. Let's see. Can you see it now?
No. Oh, okay. Gotcha. Sorry.
Are you able to see it now?
Not yet.
Oh, not yet.
Bear with us for a second.
Let me stop sharing and I'll try again.
It's showing on Zoom. Oh, Lisa, it's not from your end. I think it's one of our tech issues.
Oh, okay. Okay. Let me know when that's sorted. Is it sorted? I think I see it in the background.
Yes.
Oh,
Right.
great. All right. Super. All right. Well, thank you very much for allowing me a chance to talk about. I'm going to talk about the middle one, PC Cares. And I really want to start off with introductions. So you can see the United States in the pink, and I'm from Florida, and yet I work in Kotzebue and in remote Alaska, that second arrow up there. And that becomes important because the areas that I work in Alaska are very remote. They're mostly Alaska Native. They have no roads connecting any of the communities. And mainly I work with Inupiaq, Yupik, and Siberian Yupik peoples. I mention where I'm from because in the United States, firearm suicide is a huge problem. And we've talked about lethal means, and it's definitely part of the work that we've heard about over the last day and a half. We've also talked about disaggregating suicide and looking at different parts of the communities that we're serving. And so in this rendition, it's important to think about Alaska as part of the United States, but also being disproportionately affected by suicide. And then even within those state boundaries, we see disproportionate suicide rates. And these regions are regions that I work in, mainly remote regions in the state of Alaska that are dominantly Alaska Native, with very little healthcare services. So this is the Alaska healthcare system. Often people who are in suicide crisis need to be flown down to the main region in Anchorage to get mental health care. And so when we think about services and we think about adaptability for other remote and rural regions, we might be thinking about what healthcare systems are in place. Currently, as I said, our mental health systems are inadequate, they're sparse, and require plane flights to get someone who's in crisis from their home community to a hub community, then down to the Anchorage area where there are more long-term facilities. But in the state, there are no youth long-term facilities, which is an issue. So I want to quickly emphasize some things that we've seen and heard about from other presentations over the last few days. One thing is that suicide risk is more common than we think, but it is very hard to predict suicidal behavior in the near term. So I want to point this out because we know that our healthcare systems are inadequate for rural and remote communities. They're also inadequate for minority populations who might suffer disproportionately, like Indigenous communities. And our healthcare systems, as inadequate as they are, still don't have great ways of predicting suicidal behavior in the near term. So many of our patients that are classified as high risk for suicide do not die by suicide. And half of the folks that are classified as low risk for suicide do die by suicide. So I point this out to sort of emphasize and underscore that mental health services are likely not going to be the population intervention that we need in order to reduce suicide across the Americas. We've spent a great deal of time trying to figure this out. Who is at highest risk? Who's going to go on to die by suicide? When again, our assessments are poor. And they're made poorer when we have cultural differences between the providers and the people that they're serving, when those people that we're serving have experienced institutional violence, and I'll talk about that more a little bit later. But our suicide interventions tend to be fairly draconian, meaning they take away people's personal rights. They're often talk to me like hospital jail, so people lose the ability to decide for themselves where they go and how they function in their lives. And so they might be reticent to talk about their own suicide risk when they're in those institutions. So the work that we're doing is really trying to engage families and communities in reducing risk before it is acute. So trying to reduce risk across the populations that we're serving, giving more tools to families and communities. And this is an elder that we work with. This is Esther Green. And it's important to talk about suicide now and to give tools to families and communities in Indigenous communities who have been disproportionately affected by suicide. One thing to keep in mind when I'm talking about the importance of giving tools and resources to communities is that colonization for young people who are currently at highest risk in Indigenous populations is because colonization and suicide have been linked. So suicide was was unheard of and undocumented before colonization hit the Arctic communities that I work in. And now we have some of the highest youth suicide rates in the world. So we need to be thinking about decolonized kinds of interventions, like the speaker before me, and like what we'll talk about today, to try and mobilize communities, try and give more tools to people in the lives of young people to try and both decolonize, but offer resources to promote life. So the work that we're doing builds on strengths. We will talk, as we have been, about multi-sector interventions. And we haven't heard this as much, but I am a strong advocate of community-led interventions. So research can inform what people do, but it can't be the end-all be-all, especially considering the diversity of Indigenous and other minority populations who we're trying to serve and who either have rising rates of suicide or have higher rates than other communities in the countries that we're serving. So our approach that I want to talk about today is really using a community of practice approach where people who are in the lives of folks already come together, share knowledge and skills, learn from research, build trust and collaborations, and decide what might work best to tailor to their own communities and understandings. So we've developed something called PC Cares, which stands for Promoting Community Conversations About Research to End Suicide. And those involve a series of learning circles that bring together multi-sector members of the community. They're coming from communities, churches, tribes, schools, healthcare settings, to share what we know about best practices from research, and also have a chance to share what we know locally about what works and what's important for our communities at this time, at this place. These series of learning circles involve what we know about best practices from communities of practice and community mobilization, so community change approaches, where we share what we know from research, best practices, and we try and do that, what does the research show, in less than 10 minutes. These sessions are facilitated by local people who are trained to facilitate. And then most of a 2-hour session, 2 to 3 hour session, is spent talking about what do we think about that? How do we apply that to our lives, to our institutions? And what do we want to do together to collaborate to promote well-being and health in the context that we live? Our measures think about knowledge, like many interventions do. Are people learning what they need to know in order to usefully engage with prevention? Do they feel confident that they can do something to prevent suicide? And do they have other people they can work with in their communities of practice to do something about suicide? So all these are impressive and great and important, but they really lead to behaviors. The kinds of behaviors that we've been studying are interpersonal, so are people reaching out to other folks in their lives. We've seen how the mental health system is not reaching many people, and in developing world, we just saw 2% of people are getting interpersonal support through behavioral health care. So what else can we do? We can equip families and friends, teachers, pastors, other people in the lives of young people to offer interpersonal support. We can do lethal means counseling to make homes and other community areas safer for people so that they can have distance between suicidal impulse and suicidal action. As we've heard, lethal means reduction is one of the most evidence-based ways to prevent suicide. Something we haven't heard as much of, but I think is particularly important in communities that suffer disproportionately from suicide is postvention. What can we do to reduce risk once there's a suicide? Because we know people that know someone who's died by suicide are at elevated risk. And how can we increase collaborations to work with others to promote well-being and reduce risk? We've seen all of these outcomes with our two completed intervention research processes that NIMH has supported, and we're in the process of doing yet one more. The other thing that we've been studying is social diffusion. So if we only rely on those people who come to our learning circles through PC Cares to do those prevention behaviors, we're not going to hit people enough. So what we've also been studying is social diffusion. We study those behaviors and learnings from those who attended learning circles, but also include those who are close to participants. I'm really happy to talk more about this process. And we've compared those to people who are not close to participants. So we have these three groups of people: those who have participated in our learning circles, those folks who are close to those adults who have participated, and others not close to those participants. And we've been able to show a difference in participant learning and doing for suicide prevention, as well as seeing a change in those people who are close to as compared to those unrelated others. We've also been able to show self-efficacy in communities of practice within the communities who have been systematically disempowered by colonization. So giving power back to local people to host learning circles and then to learn together to do more things to prevent suicide in their communities. And so we've heard from our participants who are mainly Alaska Native, Yupik and Inupiaq, who are really pleased to see different people from different sectors engaging together in their community to address something that's very complex that will involve tailoring and different kinds of approaches based on research, but certainly directed towards their own context. Giving people the tools to be in charge of their own lives and their own programming is really important, and people have been incredibly appreciative of that self-directed aspect of PC Cares. And this is a picture from one of our recent training of trainers, where all these different folks went back to their remote communities and hosted learning circles in order to give people in their communities more tools to prevent suicide. I wanted to acknowledge everyone that's been involved in that and leave space for my other presenters to present. Thank you so much.
Thanks, Lisa. That was phenomenal. I particularly enjoyed your connection to decolonization. I think that needs to be said and addressed in a most meaningful way. I did love the fact that, wearing my implementation science hat, often we think about successful models of implementation and think of embedded implementation science, where the communities are engaged, and co-creation of knowledge, where really the investment and the engagement within the community is so vital for sustainment of the intervention. So I think PC Cares is a classic model for that. So thank you for sharing that. I also really love the biosocial model instead of the biomedical model for intervention. So absolutely, thank you for that. We'll get back to the questions, and I want to give room time for our last speaker. And I apologize if I'm not pronouncing your name correctly. Welcome, Felipe Agudelo Hernandez. He's an esteemed physician, general psychiatrist, child and adolescent psychiatrist with a PhD in social sciences, focusing on childhood, youth, and public policy. He has significantly shaped mental health policy in Colombia through advisory roles in the Department of CALDAS, the Ministry of Health, and also working with the PAHO WHO Colombia. He has led national and Ibero-American strategies for managing child and adolescent mental health risks and community-based rehabilitation in mental health. He's also a professor of psychiatry at the University of Manizales and the University of Caldas, where he leads critical research in social health within the doctoral program at the Center for Advanced Studies in Childhood and Youth. Welcome, Felipe.
Hola, muchas gracias por estar acá.
Thank you for being here. I want to congratulate Dr. Wexler, Dr. Machado, and their teams for the outstanding work. I will share my screen.
La presentación. Desde allí se ve, ¿verdad?
Can you see my presentation?
Yes, go ahead, please.
Thank you. Entonces, vamos a hablar un poco sobre el fortalecimiento.
We'll talk about strengthening self-care, the care of others for suicide prevention in Colombia. Our objective is to place the conversation about research challenges in suicide behavior from the global area to the territorial Colombia and going beyond health services, and specify changes, challenges, and progress in suicide prevention. In the Americas, there's an increase, a progressive increase of suicidal behaviors. This has been in the last few years compared to other regions. If we take a global to the local look, we see that in the framework of the pandemic in Colombia, we found out many impacts on mental health, and there's a strong association with resilience, the binge use of psychoactive substances, exposure to violences in children and adolescents. We found that before the pandemic, suicidal conduct linked problems had to do with language, somatic symptoms, fits, sadness, etc. During the pandemic, language problems, sleep problems, problems related with the upbringing of children.
Componente del monitor. Otras condiciones o
And then there were
manifestaciones asociadas.
other conditions or associated manifestations. The sound comes very choppy. We lost the sound.
Felipe, we lost your audio. Oh. Yeah, we can hear you now. Yes, go ahead, please.
It's okay.
Yes, go ahead, please.
Hay más problemas entonces del wow.
This is the interpreter. It's
Relevante ver cómo
choppy sound. Well, language and sleep problems beyond symptoms of suicide behavior related indicators in children and adolescents. And there's a strong health service framework involving public policies. In implementation, we see that there are outpatient services, community services, and also traditional services in emergencies and hospitalization. The uses that are most used in these implementation studies are the community services, and the most used in a higher degree are emergency and hospitalization related services. And we also see that out of the 11 to 13 services proposed by the Mental Health Act, only 3 to 5 are actually implemented in 70% of the national departments. And the departments where there's the lowest health service implementations are those that have the largest multidimensional poverty. So there's a strong linkage between these territories and a low service implementation. Why should we insist in the care and recovery environments? A sample is here that shows that suicidal behaviors in clinical environments are far fewer than those that come about in non-clinical environments, in the communities, in life itself. Hence the need to continue closing the clinical gap around mental health, but we also need to include other non-clinical or not only clinical characteristics. Some people are anguished because they cannot tolerate loneliness, or because they don't have what to eat, or they have lost their connection to the earth, or their territory is impacted by climate change and other elements. And this does not require only a clinical treatment. You need to recover beyond sleep and appetite and stop having hallucinations. You need to recover your dignity. And so here we have this mental health services pyramid, and we identify the challenges in those care environments. Evidence-based policies, implementation problems. We know that our territories take about 17 years in implementing evidence-based practices, and as low 40% acts on our rights focus, including participation, acceptability, availability, the quality of the services, and transparency in system resources. And all of this is interdependent. There's a strong interdependency with rights and a strong life course focus. The first experience I want to share is that of the Dovida peoples, meaning water peoples. They have a spiritual attitude, overcoming the division between mind and body and between individual and community. In 2019, given the armed conflict in Colombia, they were displaced, and so they reached a river, but the river was polluted, so they could not fish the fish that came from a place called El Choco. So these fish are inedible because the river is polluted, and so they have little access to proteins, and these people had symptoms that they explained as they felt a bad presence. They heard noises in the roof. They went to health services. The health services did not understand the interculturality or cultural framework, and so they were told that they had no manifestations. But when the Western medicine system cannot solve this, traditional doctors are called, but most of them were in Choco, and so they didn't have access to these medics. And these people started having multiple suicide behaviors in young people, two great categories with territorial suffering and a difficulty to communicate.
comunicar. Los
the
problemas
inability to communicate. So communication problems are associated to the new environment, but we also saw that those communication problems had to do with difficulty to access all nutrients needed to
pueda comunicar la angustia.
have a healthy brain able to communicate anguish.
También lo ha señalado
This is another need in the community. Here you see the list. We need to strengthen that agency to recover and reclaim lands and thereby improve mental health. So in another component, we generated with them a tool that translated the main identified manifestations to enable health services to better help them from their way to express anguish
estos síntomas problemáticos
and into finding these problematic symptoms. And also
de medios audiovisuales.
there was an audiovisual strategy to strengthen their culture. All of this had to do with the culture. Another strategy we developed is from the base of the strategy to care of others and other things is a strategy of reasons to live. This is a strategy implemented by PAHO in alliance with the Health Ministry of Colombia, and this is part of the National Suicide Reduction Strategy to reduce stigma. So this led us to list all the reasons that people have to live. And the main reasons are the family, pride on the territory, spirituality, goals, future, details, simple things, work, study, ancestors, resistance to adversity, friends, be able to witness life and the world in general or the others. So many reasons to live, and this integrated with the literature, we're designing strategies for Colombia's public policy, where we strengthen the survival abilities. We support these reasons to live with first aid in the psychology area strategies, stigma reduction, and psychoeducation about substance use, strengthen support networks, inquire openly about the reasons to live through some of the categories proposed by the people themselves, train an MH-GAP, quality rights, and EP+, to strengthen that in other care services. So we all have reasons to live, and we have to find tailor-made strategies, so to speak, to strengthen the reasons to live of other people. Another component on which we are working is the community MH-GAP and continuity of care as an indicator that is necessary in health services. That continuity of care as to the transit among all the elements involved in this care system. We see, for example, in a territory with people who had suicidal behaviors, some chose to request exclusive psychiatric care, others chose the clinic component, and others the community component with support groups, also strengthened by the clinical component, and those who participated in support groups and were in the dynamic of community MH-GAP improved, overcame some social, family, or occupational difficulties, and there was a significant improve of the Alberta scale through fragmentation, personal health relationship, and an effective response, as shown by the strengthening of the rights of these groups and what happens in peer groups. This is also necessary to recover the ability. Another strategy that we want to indicate is the one called Manizales Chooses Life. So we implemented mutual help groups in adolescents with suicidal behaviors, and there were significant improvements in experimental indicators, improvement of somatic complaints, thought problems, external problems, also social problems and internalizing problems. All of this led to a pluralism to understand the frame of these groups from mythology, which indicates how these groups value the abilities of others, and the community facilitates the agency capacity. For example, in Caldas, Colombia, there was a lighthouse. It was beautiful, and even though Aranzazu was not by the sea, it was beautiful. I remember it in my childhood. That was what a person said. The lighthouse was beautiful, even though it was not a beacon by the sea, because the village was not by the sea, but it was a beacon of hope. And this is the strategy that we have implemented to respond to challenges. It is called Mental Health Friend Territories. It uses specifically one of the frameworks with its service ecosystem to prevent suicidal behaviors based on the co-creation and value conduct to design policies. We have started by identifying all the actors of these service systems, and by each user at each level of that ecosystem, and the knowledge of that array of tools that we have in the Americas policy, the global policy, and the national policy, and the use of technology to get much closer, especially in Colombia, which is a country with a lot of scattered rural inhabitants, and we want to go from the global level to the local level in two senses. So this mental health friendly territory strategy has a few keys, such as continuity of care through image gap and a smaller fragmentation of services, and mental health with the right of access to services, and how we implement and support people's rights and the availabilities within public policy. Another component, which is called we in we, nosotros en nosotros. There we promote the community involvement of people with mental conditions. Another component is there's no health without mental health, and there we look for an early detection of other conditions or problems such as high blood pressure or postpartum depression, tuberculosis, HIV, etc. And another component, which is called yellow and violet, which is the other colors of fight against epileptics and suicide. This looks for services to have a sensitive space for mental health. And there's a proposal of new elements from culture to propose new policies, public policies, from a bottom-up strategy. We had an experience in a department called Choco, helped us to think in a different way on the national public policy. Mental health in all policies is also something that helps us to clarify the community platform, and also prevention and care of the use of psychoactive substances. I am coming to the end of my presentation. Acknowledgement to our teams from PAHO Colombia, the Health Ministry of Colombia,
y los pueblos indígenas que
and communities and indigenous peoples who have worked with us and the Health Secretariat, and especially those who continue giving us reasons to live.
espero que se haya escuchado cómo mejorar la señal con la cámara.
Thanks, Felipe. That was fantastic. I really loved that in your talk with the community that was displaced. I like how it connected both to the first speaker about the lack of basic resources that leads to suicidality, and then also to Lisa's talk around co-creation and of strategy. So it was really a nice way to wrap up this session. We have time for 3 to 4 questions. So I'll, yes, please go ahead, Eduardo.
La pregunta va dirigida a la primera.
This question is to the first panelist. First of all, your presentation was very interesting. Very respectfully, I have some doubts or some nuances as to the topic that giving money to certain people reduces suicide. I don't say that that is so. There may be studies. I'm referring simply to the experience in Argentina, Uruguay, and Brazil. I have been working for 40 years with vulnerable populations. And when we started considering giving them cash money, that is to say, in Argentina, they are called bonds. In Uruguay, they are called social help, given by the Social Development Ministry, and it has another name in Brazil. But what we saw is that people who are in poverty, not only the poverty problem is solved by giving them cash, and it stays there, but there's no counter provision to allow these people to leave this poverty situation in accordance to their own mechanisms to generate their own income. And this facilitates a situation which is not here the area of scope, but I'll mention very quickly that this allows people in these countries that when they receive these services, they get their vote, the right to vote withdrawn. They no longer can vote because there have been policies where the person is led to think that that person knows that he or she is poor. Not only that he or she is poor, but he will never be able to abandon poverty, and he or she will depend always on response. Does this reduce suicide? This is a multifactorial answer, so we need to analyze this in more detail. Governments don't generate money, they obtain money through the taxation of workers. And so the money is taken from people who work, and our experience in Uruguay, Argentina, and Brazil is that those who don't work receive that money, and in a very high percentage they use to finance the use of psychoactive substances. I don't know if you take this also into account. And so if there's no work to establish an interinstitutional synergy to make sure that these people receive money on a transitional basis and then they move to generate their income, if there's no such system, the policy will fail. I would like to have your opinion in this respect.
Thank you very much for your comment. It's a very interesting comment. It's actually generally there are some traditional thoughts on that people think that giving money to people will make them lazy, they're not going to try to find jobs. But this is not what we have been seeing in Brazil. Millions and millions of people that received this money actually got better situation and left and are no longer needy. the funding anymore. Second point is this program in Brazil, at least I cannot speak for Argentina and Uruguay. I'm aware of digital programs, but I don't know deeply the details. But in Brazil, these programs come together with training. So we give like a small, short training for electrician to hairdresser. So these people can actually get a job. And the other thing is, it's not actually a lot of money. Is that we're not talking here about giving money to a person buy a house, buy a car, and okay, you know, I don't need to work anymore. It's actually money to attend the basic needs. It's people that are hungry, they're in hunger, and they cannot even feed their kids. So, and with this point, you're actually not considering as well that there are tons of millions and millions of children that are being exposed to hunger since the first early ages. And we know that it impacts on the brain development. So the Brazilian program is focused on protecting women and children. We know that it's very important for the mothers when they're pregnant. They have the right nutrients for the brain development in the first 3 months, and also in the first 3 years once the baby is born. And imagine that there are several studies, not mine, but several studies showing that if you lack giving the right nutrients in the first 3 years, this brain can never be the same that it could potentially be in. So what we're talking here is about protecting from basic needs, and it could impact on the long term because there will be adults that was not protected when they needed to be. And I actually can not think of in mental health when someone is hungry, what we are supposed to do, give a pill if someone is depressed, if the person is hungry. I don't see how we can think of mental health if someone cannot even have the basic needs attended. It sounds very far. I think it's easy for us to discuss this because for all of us here, this is very distant reality from us. But imagine you wake up every day not knowing what we're gonna give for food for your kids. There are studies in Brazil also showing that the number of adolescents in the same group that work in Brazil, they worked on interviewing truck drivers and several adolescents that were on the roads being exploited sexually. They are no longer after the program because in Brazil, the program, it comes together with requirements. It's not like you mentioned, like you give it the money and that's it. No, you have to take your kids to school. And this impacted by taking these kids, mostly female kids, from the roads. And it's disgusting to even say that, but during the interviews was a qualitative research, and the truck drivers were complaining, I hate Bolsa Familia because I can no longer find kids on the roads paying 10, 15 reals, 20 reals, which is like $4 for exploitation of sex. So what the cash transfer is doing is not only, I think it's too simple to say it's only give money. It's not only give money, it's actually impact on the structure and on the reproduction of poverty. With what you said, you're not considering the next generations. Okay, you can blame the adults for being okay, they're being lazy. I don't fully agree with that, but if you do, you still think that, but how about the kids? They don't deserve to have the same chance that my kids will have, your kids, or the kids of us will have. That's what I'm talking about. And I actually personally cannot see mental health without this basic method. Sorry, it was long. It's too long.
Thanks, Ben. Any other questions? Oh, Leo, go ahead. Oh, Holly, go ahead, please.
Dr. Machado, thank you so much for your talk. I think my question might be similar to what you just expressed. I had the privilege to speak with someone earlier this week who's doing research in Ukraine. And in that context, the women who have been displaced in Ukraine were receiving a stipend from the government. And then it stopped. And the study doesn't know yet what's going to happen to their mental health. So this made me wonder about your study, whether or not you've looked at or anticipate long-term outcomes and changes in the behavior of the people who went through the program that might then also continue to impact suicide rates without the intervention of the cash transfer. I hope that made sense. Okay. We are with the project that I'm working on at the moment. We are gonna run in the last 2 years some forecast models to see if the increase the coverage, what would happen with the suicide rates and also mental health hospitalizations due to mental health disorders, and to see if it increases, what we would expect as rates, and decrease, and also we're gonna simulate different scenarios to see what's gonna happen. But I really like your suggestion of also trying to check specifically with those who stopped receiving. We would expect a long-term effect, but we don't have the answer right now for that. But it's a very important point that we should evaluate for sure.
Thanks, Dan. Leo, go ahead. I'll come back to you for.
Yeah, I have a comment and a question for you, Diana. The comment is that exchange between the morality and potential unintended consequences of cash transfers reminded me of the political and academic debate around universal basic income. There has been a lot of, well, of course, political discussions, but also academic literature around that. And it just reminded me of a very interesting chapter written in a book called Good Economics for Hard Times. Chapter 9 is called Cash and Care. And it uses data to analyze some of those debates around universal basic income and the potential benefits, not only in mental health, but also very important social intended and unintended benefits of it. Just, I'm not a stakeholder of the company that wrote the document, or not a co-author of the book either. My question for you, Dr. Machado, is the following. You are analyzing the correlational and causational links between poverty and or lack thereof and suicidality. There is some literature in different parts of the world that take that one step further. And my question is if you have the data or if you are already looking into that, which is once individuals have better mental health status, there are economic or social positive effects by the way of, for example, improved productivity or improved taxation or decreased admissions to hospital or improved, for example, academic attainment in children. So are you looking into the social outcomes of those improved mental health outcomes that come as a result of less poverty?
Sorry. Yes, we are. We actually have on the review paper now that we are evaluating the impact among hospitalizations, and we are also seeing a decrease in the psychiatric hospitalizations among those who received the cash transfer. And one of my postdocs is doing this, and I have another postdoc who is looking among people who got hospitalized by a psychiatric disorder, means like the severe patients, if this is decreasing the suicide rates among them. She also found an association. So we are looking into some specific in mental health, yes. In regards to the basic income, I'm aware of that Finland has implemented that a time ago. They are testing doing it. I would say that we have to evaluate the context. I think the idea is fantastic. So for the basic income, for those who doesn't know, means that everyone, once you're born, you receive the fund, doesn't matter your income. The Brazilian program is not like that. For a Brazilian program, you have to be poor or extremely poor. So the reasoning behind is different. And I would say it depends on the context, because we also have to consider the economic status of the country. For Brazil, we need to do more tagging, because maybe financially it would not be sustainable long-term to do the basic income right now. The other discussion that's very interesting is about should it be conditional or not conditional. I revised a paper done here in the USA, and the authors were arguing that should not be conditional because we are treating people as kids. Okay, I'll give you the money if you do that. But I don't agree totally. I think it's a context specific matter, because in terms of Brazil, we needed to take the kids out the street now. We need to take these girls from the roads now, and we cannot wait until you change for the next generation to understand that you have to take your kids to school. So for Brazil, I would argue yes, we need the conditionalities.
Thanks, Diane. We have a question from online.
Thank you. Can you hear me?
Yes, we can. Please go ahead.
Thank you. My question goes to Lisa, regardless the community, let's say community engagement, especially when he talks about indigenous group, and especially in the context what we mentioned when he mentioned about the post-colonization and self-empowerment. So can you elaborate more on how the traditional, the indigenous group traditional beliefs or spiritual harmony becomes a protective factor and not a risk factor, especially when we mention about their empowerment in the post-colonization process? As I'm Raquel from PAO, but working in Suriname, and we have this diversity of population, and also we have this big population, and would like to hear what are the examples you can provide. Thank you.
Thank you, Raquel. I think that's for me. So there's been a lot of research looking at resilience and protective factors and cultural practices, ceremony, self-determination. All of those kinds of culturally embedded things are protective for young people. It's especially important to have role models that are like them, where they can see a future that makes sense to them. We've done a lot of narrative research, a lot of sort of arts-based research with young people. And we've also done some descriptive work looking at what conditions within a community seem to be associated with a reduction in suicidality. And so some of those things look like self-determination, look like coordination between the institutions within a community that work together to provide opportunities for young people, continuing ceremonies so that young people, for instance, have rites of passage that they can engage in, where we're celebrating and uplifting cultural strengths. So those are some of the ways that we're seeing that. And then empowered, and so I'm trying to remember the second part of your question, which I'm gonna...
Yes, I was mentioning about the empowering the community, especially the post-colonization. You mentioned some ideas about it, and how can it be linked with to become a protective factor and not a risk factor, because those groups of population, they no longer all live on their area. They interact with other groups of population with more globalized ideas, and how you see in your research about it.
So that's coming from a lot of different places, and it's a complex answer, and I'm going to answer very quickly and incompletely. So I think when we create opportunities for local people from communities to be leaders, to be mentors, to get the benefits from the research that we've done about best practices so that they understand how they can take what we know from science and put it into a tailored context that makes sense for their own communities, that makes sense within their own cultures. One, there's sort of an obvious mentoring leadership that's happening locally that young people see and are a part of. And two, it is giving people opportunities to gain resources and to figure out how to put them into the best use in their own context. So I think there's a multiplicity of ways in which empowering local communities to benefit from the research that's being done is really important. And it's also really important to disaggregate sort of cultural practices from the marginalization that happens through colonization. And so I think oftentimes we think, or we don't take the time to disentangle why it is that in my communities anyway, marginalized peoples have health disparities. It's not a just because, it's not it's an intentional marginalization that is working in the lives of young people, specifically in this case, to increase suicide risk. So I think that only partially answers your question, but we found that culture, uplifting culture and strengths and local leadership is protective. And that's really an important thing, to center those things to empower communities to take care of their own.
Thanks, Lisa. I just wanted to add and get your thoughts on, so you talked a lot about how the communities will be engaged and empowered. There's this other piece where, as researchers and as healthcare workers who are trained in the more mainstream ways of thinking, that process also needs to be challenged and shifted a little bit to be more adaptive and adoptive and inclusive of these practices. So that paradigm also needs to be shifted to really get sustainment.
And if I could just add to that, because I think that's a really important point. So in our learning circles, I didn't mention it, they're facilitated by local people and they include healthcare workers. So we have mental health clinicians that are there that are getting continuing education credit for cultural responsiveness, right? And other people, like health aides, are getting suicide prevention content. So in that process of bringing people together to talk about evidence-based practices, folks who are well-versed in suicide prevention but not well-versed in the local cultural context are learning about that and getting what they need through the continuing education credits for that. And the people that don't maybe know as much about evidence-based practices within suicide prevention are getting that content. And so we really tried to make the curriculum useful for all those different groups across those sectors.
Thanks, Lisa.
Okay, I believe that is the end of our time for this excellent panel. Can we give them another round of applause, please? Wonderful. Okay, we're going to break for lunch, and we were scheduled for an hour and a half. Do we want to keep it an hour and a half, Renato, or shall we come back at 2 o'clock?
Maybe we can put 15 minutes on top of the time that we have. Like if we can be restarting at 2:15.
Perfect.
Is that okay with everyone? Okay, great. Thank you so much.
Thank you.
Últimamente estoy lidiando con mis problemas de salud mental.
I think if there was no stigma around mental health, I'd be more open about what I'm going through on the inside. And I don't know, maybe I'd find that other people in my life are actually going through the same thing.
Há alguns anos, comecei a contar para outras pessoas sobre minha ansiedade. Isso me ajudou a descobrir ótimas formas de como lidar com ela.
Soy muy sociable. Creo que si hablara sobre mis problemas de la salud mental, simplemente no lo creerían. Por eso no hablo de ello.
Me preocupa que si la gente se enterara de mi salud mental, pensarán que soy débil. Por eso me aislé. Pero creo que voy a cambiar esto.
urgently need better prevention and intervention strategies to address suicide, which is a growing public health concern. The national suicide rate is rising, and one of our highest priorities here at NIMH is research aimed at reversing that trend.
The type of research that NIMH is supporting in suicide prevention right now is focused on finding people at high risk. So people who've attempted suicide, people who've thought about suicide but may have not yet attempted. And we're focusing on the healthcare system because we know 80% of people who've died by suicide have already been in the healthcare system. We're trying to improve the healthcare system's ability to detect and treat and prevent suicide.
NIMH-funded studies have led to the development of simple screening tools that improve providers' ability to identify those at risk.
So we created a suicide risk screening tool called the ASK, the ASQ, and it stands for Ask Suicide Screening Questions. And this has all kinds of materials to help physicians and nurses manage people who screen positive for suicide risk. So we have a brief suicide safety assessment. We have a flyer to give out to parents. We have a script that you could train the nurses to use to administer the screening questions. We believe that if nurses and physicians in the emergency room, the inpatient medical surgical unit, the outpatient pediatrician setting could use the ASK to detect suicide risk, that you could save young people's lives.
A healthcare provider should be able to sit down and talk to somebody and do an assessment to understand that person's risk factors and think about what could be treated, what's bringing that person to this point that they're thinking about ending their life. Do they have a mental health problem? Are they experiencing stressful life events? That should be an opportunity to start working on these problems.
Screening tools are one approach to identifying people at risk for suicide. Another approach is to use electronic health records that are collected as part of every healthcare encounter.
We have shown that when one has linked data connecting information on people's health and healthcare on the one hand with information on who goes on to attempt or die by suicide. When a health system or a health plan has data like that, we have shown that one can develop statistical methods like a credit card company identifying fraud. Health systems or health plans can identify members of their beneficiary population who are at high risk for suicide to reach out and offer them additional assistance.
Knowing who is at risk is just the first step. The goal of our efforts is not only to identify at-risk individuals, but to help them to improve their quality of life and to prevent suicide attempts.
We have interventions that work, but we've learned that they're not being implemented in real-world communities. And so much of the focus of the research right now is to figure out how it can be implemented in communities by trained professionals who do the interventions how they're supposed to, and to take the interventions that we have and to optimize them so that they work better.
I think there's good reason to hope that there are many things we've learned that could actually be implemented today and could actually save some lives. I think we're getting a better picture on the trajectories of what's causing suicide so that we could intervene earlier and prevent people from being in a crisis.
Thanks to our research efforts, we can identify those at risk using evidence-based practices, and we have effective treatments currently being tested in real-world settings. We have the tools to save the lives of thousands of individuals, and we are continuing our research efforts to combat suicide and give all new hope.
The COVID-19 pandemic exacerbated many problems across the Caribbean region, one of them being the lack of access to mental health services. Recognizing this, the Pan American Health Organization, PAHO, set out on a mission to strengthen mental health and psychosocial response to COVID and other crises in 3 Caribbean nations, including Suriname.
When your mental health is at stake, that a lot of things also can go wrong.
And unfortunately, this led to a shocking number of suicides in the country.
in that period, we had an increase of suicide cases in Nigeria. So when we were there, I think every day we were there 3 to 4 days, and every day that we were there was a case.
And through the PAHO-led project, the Bureau of Public Health in the Ministry of Health in Suriname engaged the public through trainings and outreach programs to address the far-reaching effects of mental health.
In the period of COVID, mental health was not forgotten, and that a lot of activities were done. For instance, we made sure that some people got some information, so awareness in our population about mental health. We held some panel discussions, for instance. 4 panel discussions were held. We also had a radio program for elderly with 2 doctors who made it possible that the people could call and ask some questions. The same thing was done with the panel discussion. We had training, basic psychosocial skills. We had a launch of 2 trainings from the PAHO, who we asked the PAHO to translate these trainings for us. So it was psychological first aid and suicide prevention training.
And these trainings and information sharing sessions were successful, very much welcome and impactful.
The project was very successful because we had a lot of different aspects to this project. They were very happy with us bringing them this training. So I was very happy that the PAHO had given us the chance to also bring their training all the way there to the people. There are a lot of people who are willing to learn. They are willing to learn what the key points are in seeing the signs for suicide prevention, so we can prevent this, because every suicide is one too many.
The effects of the COVID-19 pandemic on the region of the Americas extend far beyond the lives lost to the disease. The care needs of most people in the region living with mental health and substance abuse conditions have remained unmet, especially those living in conditions of vulnerability, including historically discriminated populations such as Indigenous and Afro-descendant communities. PAHO's High-Level Commission on Mental Health and COVID-19 developed the new agenda for mental health in the Americas with 10 recommendations and strategy actions that are crafted for incorporation into countries' post-pandemic recovery strategies. 1. Elevate mental health at the national and supranational levels. Establish mental health as a national development priority, including mental health in universal health coverage, and develop strategic partnerships and alliances to advance and advocate for mental health at the national level and beyond. 2. Integrate mental health into all policies. Promotes the integration of mental health into all areas of health, as well as across sectors and in emergency and disaster responses. 3. Increase the quantity and improve the quality of financing for mental health. Outlines how to mobilize increased financing for mental health and allocate it more efficiently and equitably. 4. Ensure the human rights of people living with mental health conditions. Advocates for strengthening human rights for mental health through legislation and policy, transitioning services from psychiatric institutions to community-based care and capacity building in human rights across sectors. 5. Promote and protect mental health across the life course, including childhood and adolescence, adulthood, and older age. 6. Improve and expand community-based mental health services and care. Delineates actions to improve service coverage and quality by integrating mental health into primary health care, making services culturally competent, harnessing digital interventions, building capacity in mental health and psychosocial support, and empowering service users and their families. 7. Strengthen suicide prevention. provides concrete guidance on evidence-based strategies to prevent suicide and its risk factors through the development of national suicide prevention strategies, public policy on means reduction and alcohol use, and capacity building to respond to self-harm and suicide. 8. Adopt a gender transformative approach to mental health. Lays out actions to reduce gender inequalities and address gender-based violence and harmful masculinities, key threats to mental health. 9. Address racism and racial discrimination as a key determinant of mental health. Emphasizes the need to combat systematic racism, targeting indigenous peoples, people of African descent, and other ethnic groups by working with these communities to understand racism and its potential solutions, establishing national action plans against racism and racial discrimination, strengthening policy and legislation, and creating anti-racist environments. 10. Improve mental health data and research. Proposes actions to improve the availability and quality of mental health data through the expansion of mental health data collection, data disaggregation, strengthen monitoring and evaluation, and research in priority areas of mental health. Let's work together to create a world where mental health is the top priority.
Greetings, I'm Congressman Adriano Espaillat of New York, and I am pleased to recognize Dr. Jarvis Barbosa da Silva Jr. and the leadership of the Pan American Health Organization and the World Health Organizations to help build the bridges that prevent suicide across the Americas. The investments we make today in programs and initiatives will help save lives and help our communities thrive forward. We are appreciative of the efforts of PAHO and your work to support individuals and families around the world.
La pandemia ha afectado gravemente la salud mental y el bienestar de millones de personas, en particular las mujeres, las juventudes y los grupos que ya de por sí estaban vulnerabilizados. El confinamiento, el cierre de las escuelas, el teletrabajo, el cuidado a los diferentes integrantes de la familia ha significado una presión adicional para las mujeres.
One of these structural challenges is the growing toll that the pandemic has taken and continues to take on mental health in the Americas.
Hoy más que nunca miramos la ansiedad en jóvenes, en hombres y mujeres relacionados con una pandemia oculta que teníamos antes de la pandemia del COVID-19, que es la salud mental.
The work of this PAHO High-Level Commission on Mental Health and COVID-19 is timely, relevant, and indeed urgent. It's a necessary step towards deepening discussions and solutions aimed at improving mental health in the Americas.
The effects of the COVID-19 pandemic on the region of the Americas include devastated economies in the region, unemployment, poverty, inequality, and many more. Mental health conditions have surged, while mental health services have struggled to meet the new, increased, and urgent demand. The Pan American Health Organization convened the High-Level Commission on Mental Health and COVID-19 to help policy and decision-makers by providing clear guidance on how to best advance mental health during and after the pandemic. The Commission includes 17 members representing governments, health organizations, academia, civil society, and people with lived experience from across the region. It is led by Her Excellency Epsi Campbell Barr, former Vice President of Costa Rica, and Ambassador Nestor Mendez, Assistant Secretary General of the Organization of American States. The commissioners worked throughout 1 year, consulting with experts, directors of mental health programs, and representatives of civil society organizations. The result? A new agenda for mental health in the Americas. Focused on actions in the immediate term, this new agenda aligns with current global and regional mental health and development objectives, including the WHO Comprehensive Mental Health Action Plan 2013 to 2030, the PAHO Policy for Improving Mental Health, and the 2030 Agenda for Sustainable Development. The NAMHA outlines 10 recommendations with corresponding action points, accompanied by case examples from the Americas which highlight successful models to guide implementation. It presents evidence-based approaches to address the crisis generated by the COVID-19 pandemic in the short term, while laying robust foundations for the longer term, to ensure optimal improvements in mental health care in the region of the Americas.
The time is now. Do your part to support mental health. The Pan American Health Organization and the High-Level Commission on Mental Health and COVID-19 together are counting on you to help reduce stigma and discrimination this October 10th, World Mental Health Day. Fear, misunderstanding, and prejudice exacerbate this stigma, as do social exclusion and discrimination of people living with mental health conditions.
We must all unite, the government, public and private institutions, healthcare professionals, community, organization, women, men, youth, and boys, girls of all the Americas to fight against stigma and discrimination. The PAHO, High-Level Commission on Mental Health and COVID-19, is working to develop guidelines and recommendations to make a significant progress in mental health and advocacy in the Americas.
Seize the moment. Do your part to support mental health.
La pandemia debe de servir para dar un salto cualitativo en el bienestar de las personas, en ese bienestar emocional, físico, económico, cultural y social. Bienestar que implica que entendamos que la salud mental se convierte en un eje central para garantizar los derechos humanos a todas las personas, especialmente a las mujeres.
The work of this PAHO High-Level Commission on Mental Health and COVID-19 is timely, relevant, and indeed urgent. Addressing the connection between mental health and COVID-19 is a necessary step towards deepening discussions and solutions aimed at improving mental health in the Americas.
Este espacio debe permitirnos promover una declaración política, un acuerdo político, un pacto, entre los estados y entre la sociedad como un todo para asumir acciones concretas a las necesidades de mujeres, niñas, jóvenes, afrodescendientes, indígenas frente a los impactos del COVID-19 en su salud mental.
Good afternoon, colleagues. Welcome back. We are reaching the end of our symposium, but we didn't want to finish before having the opportunity to discuss many of the important topics that were highlighted by the panelists today and yesterday. So we thought that this session called Concluding Reflections could be an opportunity. What we were planning is to go through the panels and give the opportunity for all of you to bring to us what you think was the most important thing discussed, what you will be taking from here to the place that you do your research or that you develop policies and implement activities. So we will go panel by panel. And what we also thought is that as we didn't have time for questions and answers during especially panel 1 and 2, we can also take some time to let you ask the questions that you want to ask or make the comments or interact with the panelists that are still here. So that's the plan for the time that we have now until around 3 o'clock. Yeah.
So that will give us 40 minutes, like 6 to 7 minutes per panel. Is that all right? Right? Okay. So just want to all kick off the conversation and the discussion by asking each of you guys, either in English or in Espanol, what are you guys learning in panel 1? What did each of us learn in the surveillance panel? What, what message you taking in your notebooks, or what idea, draw your attention? I'm really curious to know what you learned or, was struck by in panel 1 in surveillance. So please feel free to open your mics and share. Brandon? And may I suggest one thing? Those of you that are not in the main table, please feel free to come and join the main table and take one of the seats, including mine that is not occupied. So please feel free to do that.
And mine too.
So I mentioned some of it this morning in the reflections, but I'm very curious for any of the individuals from the different countries that were presenting their projects. I think one of them was the group from Uruguay, and other individuals, how they're trying to capture this information on attempts, because it seems like that is a very important group, and I'm curious also maybe in Trinidad, Tobago, how that information is being collected and then how that information is used, because often we just get the number per 100,000 in terms of deaths, but it seems like being able to get a better sense of attempts might give us a sense of when things are improving with public health interventions or messaging. So just interested in any reflections based on this data on attempts, not just deaths in the suicide surveillance.
Thanks, Brandon. Any reactions or responses to that specific question?
Hola, buenas tardes.
Hello, good afternoon. Thank you for the question. Right now, we are in the early stages of developing the system. We have data for 1 year. What we're doing now is we're doing the epidemiological characterization of data, looking at individuals, how old they are, who they are. Okay, can you hear me? So I was saying that in October, it will be 1 year since we started in October 2023.
Okay.
Testing, can you hear the interpreter? Thank you. Yes? Testing the English channel. Testing English, 1, 2, 3, testing. Testing 1, 2, 3, yes.
Bueno,
Okay.
contaba que en octubre de
I was saying that in
2023
October 2023, we completed our data collection for 1 year. 1 year. Testing, 1, 2, 3, testing. We're still testing. Yes, can you hear me? This is the English channel, yes?
I think other people can hear it, might just be his headset. Like I can hear it.
Testing 1, 2, 3, testing again, testing the English channel, 1, 2, 3, testing.
Okay, sí.
Yes? Okay, can you?
Okay. Bueno, tenemos recientemente.
So I was saying that we've just completed collection of 1 year of data from October 2022 to October 2023. So we began by doing the epidemiological characterization, looking at what type of people they were, where they lived, how old they were, what the age range was, and this was for suicide attempts, whether there were repeat attempts. So we're drafting an article which does just that. It outlines the profile. That's our first project, and we're also working with the node on sanitary intelligence in Uruguay. It is a core group where there are technicians and researchers who are experts so that we can cross-reference data. The first database we decided to use is the one of individuals who have attempted suicide or death by suicide. So to see how many people who attempt suicide succeed and whether there are individuals who have attempted suicide several times. Our countries may be very different as far as this is concerned, so we'd like to have a clear picture of for our population, and then we plan to cross that with other databases. Since the information is anonymous, we would like to also look at databases of individuals who receive social support to see if quality of life is a factor in suicide attempts. We've done this to a certain extent. We also want to find out their profession, if they're retirees or if they're law enforcement. So that is where we are right now, and we're trying to find partners to collaborate, to do the research and also publish this in high-impact publications so that we can provide or share our work at the international level. Brandon, I'm trying to understand your question. Did you ask how data is captured and how it can be used? And what I would say to that is that data capture and interpretation has a public health value in and of itself, but it may also be of clinical value at the individual level. It may enable us to take actions with regard to higher risk individuals and have predictive models that enable us to anticipate the groups that should receive priority attention, so we can work with ex post or go from ex post descriptive models to ex ante interventional approaches. Was that what you were asking?
Exactly, yes, both the population level benefit and the individual level benefit. Fantastic. Yeah.
Belén y luego Belén.
Sí, para complementar.
I'd like to add that we too are starting to perform surveillance of self-harm cases in emergency rooms, and we're using that to identify cluster suicides. We can do this for younger populations practically in real time. So we use this in a way that is forward-looking, but we also look back and see what data can point to trends in terms of groups associated with cases of suicide, and also to rule out some groups. and that would help us to target our assistance to the right populations to prevent the phenomenon from expanding at the population level. Thank you, Belen. Alejandro, one final comment, and then I'll give the floor to Renato for panel 2. From a clinical standpoint, I may not have understood the question originally, but what we're doing with data now, we're looking at who those individuals are to ensure that there is continuity in the care provided to them. So we have a team from the ministry. They're doing epidemiological surveillance, and they identify the individual, they contact the person, the family, and they provide follow-up care. Thank you, Alejandra. Before I give the floor to Renato, something that struck me, I'd never thought about it. I don't know what semantic value it may have, and it's that in many of our countries we use the word suicide. In the US, the word used is also suicide, but in Uruguay you call attempt to self-eliminate. So when I hear self-elimination, I think that term is quite impactful, at least for me.
As we need to move on, you might remember that panel 2 was a very interesting panel with very rich discussions. The theme was reducing access to lethal means, and we discussed mainly pesticides and firearms, with experiences here in the US, also in some of our Caribbean countries. So any comment you'd have, any specific point that you extracted that it's important for you, if you also want to ask questions, the panelists are still here. That's a very important theme. It's probably the best evidence that we have for reducing suicide mortality. Mark, please.
Yeah, I thought it was a really important panel, as you say, because it has the best evidence. And one of my reactions is that a lot of the purveyors of these different substances, let's say it's pesticides, but I also think about drugs that are used in self-poisoning. The companies that produce them are international, and the problems are international. I was in Australia last year and was attending a meeting in which they were presenting data about self-poisoning deaths in Australia using over-the-counter drugs. It could have easily been delivered in Toronto, where I live, because all of the issues were exactly the same. And so I think one of the things we have to think about, obviously at a country level, we have to think how we're going to deal with the problem, but we might need to think really holistically internationally about how we as a group of nations approach the various purveyors of these substances and think about how we might be able to decrease access in a logical way that still allows the economy to function.
Belen, please.
Sí, la verdad es que más que una reflexión me voy con una gran pregunta.
Rather than a reflection, I'm leaving with a major question about reduction and prevention of lethal means. We've seen figures from Mexico and also Uruguay, Alejandra will confirm, but in Latin America, it is as hanging that is the main cause of death. So I'm leaving with questions. How can we reduce the access? And this is so much more complex because at least in Chile, it is within the homes that it occurs. So there are no measures we can take, such as public building, as in the case of jumping from high levels. So this is something that we need to look into. And hopefully in this collaboration that we're setting up for Latin America, we'll be able to focus on it.
Perhaps the colleagues want to comment. Gamini, please.
Well, thank you. I think this is a very important point you brought up. And it immediately brought me to about 30, 40 years back, what happened in Sri Lanka. It was the same those days. It was hanging. For very unfortunate reason, it switched to pesticides. So I'm not saying which one is better, but what I'm saying is, this communication comes, I think somehow play a role in this one. At least in Sri Lanka, it happened because first few suicide deaths due to pesticides were highlighted on newspapers and everywhere, like in the normal cases, and everybody diverted their attention to pesticides, leaving hanging behind. So now pesticides are not lethal in Sri Lanka anymore. So they are trying still with pesticides, but they don't die. So hopefully they will not go back to hanging. So this is what I wanted to say. This is just a comment and nothing much to add, of course. Thank you.
Thank you, Gamini. And I extract a very important message here, because the fact is that many of our countries, highly hazardous pesticide is not the main mean of suicide, but I think there is always space to work on limiting, restriction, and banning those horrible substances, right? Sorry, please.
También creo que algo que nos llevamos todos.
Something else that we're taking home with us is in that area of communication, and it's the situation that the safe schools person was telling us about. In our countries, this type of information isn't necessarily available. You might be watching TV and it talks about safety at home for children, but it doesn't happen in our country. So this is some homework that Mexico is taking home. We need to work on that in order to launch campaigns for safe homes, for safe schools. We do have a little bit more already ready, but I found this very interesting. Safe homes is something that is extremely important. Thank you very much. One of the things I'd like to add is the importance of identifying which are the lethal elements that are most used. And hanging, as Belen said, from my clinical perspective, I'm a clinical psychologist and I work in these collaborative approaches essentially. So some homework that we're taking back with us is how to continue linking the chief strategies identified in the world to prevent suicide, which is access to lethal elements, and second, a safety plan. Evidence-based models have an get closer to adolescents and families, and we work collaboratively to identify those methods that are potentially most used. So rather than a restriction, it's just a matter of implementing a barrier, because otherwise the perspective would continue to be focused on only preventing death due to suicide. And I think that is something that we need to change. It's not only a prevention of death due to suicide and the structural barriers we face, but to understand why somebody has this desire to take their life. And in that understanding, working together with the family and society in general, then perhaps we will find different ways not only to prevent these deaths, but to promote lives that are meaningful to people. This goes beyond what is structural. It involves family participation and closer, more careful, validating, and warm relationships. So we're all involved to achieve prevention, proposing resilient factors and lives with meaning. Thank you very much.
Last comment for this session, and then we move to the next one, please.
Okay, I appreciate all these comments. In the United States, there's been the utilization of safety planning, which you just mentioned, right? So there are 6 components to that. And the 6th and final one is talking about creating a safe environment. So there's a recent paper that was published that said that's really where a lot of these interventions fall short. Generally, they aren't delivered with a whole lot of great quality of care in emergency departments, but that's the one where the clinicians, I believe, feel the most reticent. They're hesitant to go into that discussion, especially around firearms, right? So I think that the basis for these discussions in any good suicide prevention care is based on trust. That has to be the complete basis for it. So if you're talking about something like dying by hanging, to get to that point, you will have to have earned that person's trust, and you have to identify that that's the plan that they have at that moment in time. And then you're kind of at the point where you're trying to convince them that they should accept the help that you're offering. And that's also the case with firearms too. And I guess what I'm most concerned about is that if the clinicians are not well trained to have those conversations, they could unintentionally be doing things that are having the exact opposite impact that we hope to have. We understand that that's the case often when we try and talk to people about their suicide experiences, and we try and convince them, you can't be suicidal, you have all these things to live for, look at your family. And that's really invalidating to them. And if anything, that's kind of creating less of a collaborative relationship and a friction. So then if you look at the same thing when we talk about why should you, surrender access to something that's so important to you, that takes a lot of trust. And, we need to be able to train the workforce to have those conversations in an effective way. And I don't think that we completely fully understand how to do that effectively. So I just want to put that out there. It's important to have those conversations, but you also don't want to jump in, well-intentioned, but you're actually potentially doing more harm than good.
Thank you very much, colleagues. Thank you, Stephen. We move forward to the next session, Leo.
Yes. Am I allowed to make a comment on the last session, Renato?
Of course you are allowed to.
Stephen, you just made me think of, as a clinician, when I was doing my best to do safety planning in the ED, trying to be empathic with the patient and not invalidating. And also, trying to do my best as a clinician, but also thinking now in retrospect, whether the workflow in our clinics and hospitals and health systems, the pressures that we have to see multiple patients at a given set of time. So the environment is conducive and the incentives are conducive to create those positive relations with patients, particularly in the ED. Sometimes they are, sometimes they're not. I was just reflecting on that, my own experiences. Thank you for that. Panel 3, fostering social emotional life skills for adolescents. We heard from Belen yesterday, from Michael, and from Diane Regis from UNICEF. Comments, questions, ideas, things that you want to take home, but you also want to share with us in the audience live. Stephen?
One quick comment. Epidemiological data demonstrates that in young children, a suicide was often preceded by a difficult interaction with a parent. In adolescents, a suicide is often associated with a difficult interaction with a significant or romantic partner. And in adults, a suicide is often preceded by a difficult interpersonal interaction with a family member or a significant other. So one of the things that Dr. Lindsay is focusing on in his intervention is trying to help youth develop the skills to tolerate a difficult interpersonal situation. I think that that's really important because that's the specific link to suicide risk reduction. There's a lot of really important elements to include in social emotional learning, but I think we really want to drill down on the specific skills that we think are going to be associated with suicide risk reduction in particular. That probably involves emotion regulation, interpersonal skills, and distress tolerance.
Thank you. Thanks, Stephen. Please.
Just to, again, share some of my experience relating to adolescence back in Sri Lanka. One thing in general, what I found was, again, another component of this whole complex thing is easy accessibility to lethal means, especially in rural communities, in farming communities. Pesticides are right everywhere in their houses, in the kitchen and the rooms and everywhere. So I have seen many instances where they simply can go to a room and grab this thing and drink. So these adolescents have done it many times. So that was the easiest accessibility. So this is another aspect of the whole thing. While the mental health issue is really something very important, but accessibility part is also playing a key role in this one.
Thank you.
I'm obliged to connect the comments from Stephen to Brandon, if I may. Brandon, I know that you're specialized on that. How can we integrate the skills that Stephen has mentioned into a non-specialized workforce? Because that's what we have in most of our countries.
Thank you. I think that that host of interventions that UNICEF had presented yesterday is a good start to that. So a number of those are being tried out. I want to put a call out, though, that for the most part, those current interventions that are being described, when we say they're evidence-based, most of that has been in terms of distress reduction. And we haven't yet evaluated those interventions for actual suicide prevention and kind of those preceding mechanisms. So these issues related to emotional regulation, how much can we show that that's happening? I think we have to find out, because distress may go down for many different reasons, and we want to know that it's actually that distress tolerance. Building on what Dr. Machado was saying, I want to mention one study that's currently going on in Colombia, but also South Africa and Nepal, and that's funded by the Wellcome Trust, and it's looking at cash transfers combined specifically with self-regulation interventions to be able to see that combination of both the economic resources and specific self-regulation skills, and that'll look at prevention of these behaviors going forward. So hopefully we'll have new data in 2 or 3 years on that.
Claudina?
It's just so interesting to, as we listen to each one of the panel 1 with surveillance, panel 2, reducing access, we are now in 3, which is a vulnerable population. But I think I like the fact that, and I remember one of the presenters when they were talking about the fact that you cannot have only one, we have here people from pesticides, gun control, and I really want to just put it together there, because what Stephen was talking about, health sector, and if they're not prepared. But I'm wondering that even for the adolescent, that the conversation cannot be only health, as we know, because most times health are not even prepared in terms of how to address the challenges. And this is a very difficult age, as we all know, in terms of challenges. I don't think we touch on all the different groups that are vulnerable, like LGBT, and how you address that, and how you prepare the health sector to be able to understand their challenges and their issues. And so most time they come and they quiet, they don't talk, they won't be engaging. So it would be good to hear. I know there's so many interventions out there, there's so many tools that are available, and yet I find that sometimes we're still failing to this population. So it'll be good to see what are other ways for us to reach this vulnerable group. So just a reflection there.
Thank you, Claudina. I have a question for you guys. When I was listening to Michael Lindsay, and then you brought that up, Stephen, when he mentioned that data supports the notion that difficult interactions with parents can lead to, of course, increased distress, but suicidal ideation attempts in children. I wanted to ask if there is any data showing that corporal punishment, which can be very prevalent in some nations in the Americas, but of course in other regions too, is there any data showing that specifically with corporal punishment in children? Alejandra?
conozco que hay datos referentes.
I do know that there's data relating to depression, but I don't know as far as corporal punishment or physical mistreatment and suicide. It is linked to depression, and maybe there is a tangential link to suicide.
Muchas gracias. Pasamos al panel 4, Renato.
Thank you very much. Let's move to panel 4.
About responsible reporting on suicide. So we really had fascinating presentations. Mark Senior was with us. We also had the journalist that expressed her perspectives. Dr. Hazel Othello also brought the experiences of Trinidad and Tobago, which is a country that has been shown very important reductions on suicide mortality in the last years. We've heard about Werther effect, Papageno effect. So what did you guys extract? What do you think are lessons learned that you can take home? Arantxa, por favor.
I'm going to speak Spanish. One of the ideas that I drew from the presentations that were given yesterday, and especially listening to Annette and Hazel, is the need for these efforts to work with reporters and the media may be sustainable over time and repeated. We saw the example of Trinidad and Tobago, where the impact was positive, but in the last year, as we saw on a graph, the press reports are once again reflecting those characteristics that they had at the outset. So it is necessary to maintain it. Working with the media, one knows that there's a lot of turnover of staff. And Eddie says that news isn't provided by a person, but a team. So perhaps what we need to consider is working with the teams of journalists in the traditional media, whether it be newspaper, radio, TV. The social media is a different world. But we shouldn't just think of one journalist who has not much power because of the very dynamic and the competition from other types of news and so on. So these two ideas, to repeat and repeat, not just provide training 1 year. No, we have to continue being insistent with it. And also seek out other examples, working with larger teams, with structures that function well. And something important that Annette shared with us is that new journalists, they're defenders, not advocates. And I said this when I was in charge of press, and I would tell doctors, they're not your friends. They don't want you to look good. They need to do their own work. And what you can do is show your work, show your data. So they say they want to improve the community, but not necessarily defend our interests. And that we have to bear in mind. Hazel spoke about this also. We're talking about rape, for instance, and Annette said, it's not that we want to do our job poorly, but here we have worked in the journalism of solutions because reporters want to solve the problems in their communities. That's why one adopts that career. So sometimes the reporters show the problem, but they can also show what works, just as we're seeing here at this symposium. So that is something that we can show them also. However you write your article, you can either save lives or unwittingly you may cause other people to lose their lives.
Pamela, please.
Here we go. Yeah, so thank you for those comments. That actually just makes me think about, yes, journalists have a role. They have reasons for reporting as they do. But this also seems that it might be an opportunity to say communication must be a part of suicide prevention, right? And maybe it's not the journalist that does this, but maybe it's figuring out what is the role of someone else who's a part of the team that's, whether it's, community mental health team, whoever it may be, but what is the role of communication and how can we learn from some of the skills that journalists bring and just understand the best ways to utilize that, creatively. I actually thought, I had never heard of the Papageno effect, and I thought that was quite interesting and certainly underreported, right? I don't think most people are aware of that. So that seemed like things like that we might learn how to capitalize on by making them a more routine part of suicide prevention.
Thank you, Pamela. What also came to my mind in those discussions, and this is probably a follow-up conversation with Arantxa and the communication team, how could we be more strategic here, probably reaching, if there are regional associations of communicators and journalists, so we might be able to pass those strategic messages or integrate responsible reporting courses into the curriculum of schools of communication and journalism. I think that could be opportunities to have a higher impact in the whole region. So something that we can try to study here and see if there is a way through. Okay, colleagues, that was panel 4. Back to you. Sorry, Claudina, please go ahead.
Because I really like the presentation too, and I like the property, but I like when you were talking about because that's the theme, changing the narrative. Was there anything behind that, like any ideas about changing that narrative, whether we should, what it is that you had in mind? I thought it was interesting that you mentioned.
Right, it's a fair question, changing the narrative, but what's the what do we change it to? I think the answer is back to that notion of the Papageno effect, and I guess maybe I would link it. I think we have to think across the whole live life, and I was thinking about something that Stephen was saying before. So much of our media does what Aneri was talking about yesterday, which is that they come up with a specific issue, which is maybe a very real issue, and then they telegraph something that's a very problematic message. So, for example, bullying. Bullying is a risk factor for suicide, but then you have a big article on the front page that says, "Oh, bullying, killed this person," and it leads people who are exposed to maybe think, "Well, I was bullied. Maybe I would have the same issue." But we wouldn't really do that in other cases. The most common event before an adolescent suicide, as said, is an argument with parents. And you'd never have a front page article that says we have to stop people arguing with their parents because it's killing our children. Instead, you want the message, which is you are going to argue with your parents. You will argue with your spouse. You're going to have distress in your life. We should expect that 100% of people are going to experience distress intermittently all the time, and that we all need an action plan, just like we do for other kinds of, if you have a cold, you have an action plan for how you manage a cold. We all need an action plan for how you manage distress, and that everybody understands that, and that we have that message out there, so that people see a pathway to survival rather than being telegraphed that maybe they should die.
I think Claire has a comment also.
Question mark for you. I want to make sure I understood something you said yesterday, because it, draw my attention. Did I hear you saying that the way I took it is a ratio of 10-1. That was what I took in my brain. When you said, when the media reported the death by suicide of Robin Williams, there was an excess of 2,500 deaths. And the Papageno effect was 250 of prevented or reduced deaths. So I reported 10-1. And am I getting that correctly?
Your question is an active research question, which is, what is the strength of the Vircher versus the Papageno effect? And there's definitely much more evidence for Vircher than Papageno. But it's complicated because those two examples may be an apples to oranges comparison, because Robin Williams had it was a massive media event and it lasted months, and that was looking at many months of data. The study that we did for the Logic song, the Logic hip hop song probably was disseminated to a much smaller group of people, and we only looked at the month of maximum interest. And so I suspect, A, that it's probably not such a dramatic ratio, and B, that it's probably, we shouldn't actually be thinking so much about these big events. The big events are helpful from an observational epidemiological level, because you can show that something probably caused something else. But we need to think of the cumulative exposure of messages that we're receiving all the time. And my suspicion is that social contagion will work just about the same as long as the message is the healthy one rather than the harmful one.
Leo, let's move to panel 5. I think we have like 10 minutes to finalize.
All right, panel 5, improving early identification, assessment, management, and follow-up. ¿Qué nos llamó la atención? ¿Qué mensaje nos llevamos acá?
So what message do we take home? What
Just a quick comment. One of the resources that WHO has disseminated in recent years is the EQUIP platform, which is to do more competency-based training, whether that's primary care workers, community health workers, or even teachers, coaches, religious leaders. And in that, there's a range of competencies, but we have 15 core competencies, one of which is asking about suicide. And I have to say that now, after about, I think we have 10,000 assessments on the platform, that consistently the lowest competency is asking about suicide and suicide risk. And just to put a call that this room is filled with people who are very energetic and devoted to this topic. So how can we improve better training so that that skill gets to a higher competency?
Sorry, Ashley. Brandon, and I understand that EQUIP is a public good that anyone can access on the internet and download it and use it, or am I wrong with that?
Absolutely, completely free for use. All the materials are available in Spanish as well. Don't know if we have everything in Portuguese yet, but we can work on that. But yes, so anyone can use that in any setting, and through WHO and WHO regional reps, if you want to get trainings, that's all also freely available.
Thank you. Ashley?
Just to note that a couple of the projects that NIH is funding right now in Nepal is actually doing exactly what you just asked for. And so if others in the room, so we're actually figuring out implementation strategies to help doctors and other health professionals engage in those suicidal questions and responses more in Nepal and in Pakistan. And I also have a question, if I may.
Please, go ahead.
So from this panel, I was curious to learn from the other countries that in the room. There are a lot of the statistics about sort of placing suicide inquiry within the health system. Like one of the many reasons to perhaps do that is because many people might seek health services for some other reason or be in the health system before that attempt. Or that, suicides are actually happening pretty quickly after a visit to an emergency department, for example. I'm curious how other researchers have seen that hold, if at all, sort of how health-seeking phenomenon might be a precursor to suicidality.
Aquí, efectivamente,
I would say that we have several screening levels for emergency room services, and personnel is trained not to activate, not to trigger the attempt, so that it's not a precursor to an attempt. So what is done is through implementation, case management, codification. So we train the staff to make them aware, and we also emphasize the importance of trust so that the visit is not a trigger, it's not a precursor. Having said that, there's still a lot we need to learn to measure. This is a very young program, and we're missing what you just mentioned. We need to see to what extent the system is working when it comes to screening and the rest. Thank you, Belen. Are there any other comments, Richard? I thought you had your hand up.
So going back to the point about asking about suicide as a competency, one thing that we learned in our early evaluation studies on the National Suicide Prevention Hotline in the United States was that even though this was a national suicide hotline, that there were numerous times where the person answering the call was not asking about suicide, right? Now, sometimes the person would bring it up, or the circumstances might be such where, you know, the counselor would think that this is a question I should ask, but it was not happening routinely. So we published that in 2007 in Suicide and Life-Threatening Behavior, and we began a process of defining suicide risk suicide risk assessment standards for the Lifeline, including 3 prompt questions, with the goal that everyone calling should be asked those questions, even if it really seemed like, no, this person was not suicidal, you know, based. And there was a follow-up study from NIMH around the impact of training to those standards, which showed some effectiveness. So I agree entirely that the need to encourage that, and it's on multiple levels. It's for the community, family members, you know, to be willing to ask a question that feels laden with anxiety. The other thing that I think is more of a challenge for us as a field is when we're communicating about this, how to kind of integrate that. On the one hand, we're saying, please be willing to ask the question. You know, if you're a primary care physician, if you're in an emergency room, if you're on a crisis line, if you're a therapist, et cetera, you know, or if it's your family member and you're worried about them, they look depressed, be willing to ask the question. With the other side being, when we're talking about media and public awareness, our message is kind of like, be careful, be really, really careful. And there are times that people get confused about, should we speak to it? You know, and it's not an actual contradiction, but it appears to be. And I think we may need to figure out how to speak about this in a way that doesn't confuse people. And I don't think we're quite there yet.
Thank you, Richard. Puede ser corto para darle la palabra a Renato para el último.
Very quick so that we can give the floor to Renato for the last panel. I'd like to add that we are providing training for gatekeepers. And what we want is for those people to ask the question in a safe space where they're practicing. What we have seen in the field is that sometimes they're afraid to say this out loud, to verbalize it. So in the training, we have many role-playing exercises, many simulation exercises, so they can get used to doing that. It can't be just theory. They have to learn how to do this in practice. Thank you, Belen. Renato.
Because I think what we are discussing here connects me immediately with the importance of mental health literacy. Because if we as kids, as adolescents, don't learn to talk and feel comfortable to talk about mental health, it's going to be very difficult to learn when we are adults. And I think this is part of the challenges that we are facing. Panel 6, this morning, supporting research on suicide prevention. Very interesting experiences, discussions on the impact of cash transfer on mental health and how it can affect suicide prevention. We also heard very interesting experiences of projects running in the Alaska. And every time we are discussing those projects, it connects me immediately to some of our countries that also have populations distributed in areas that are very difficult to reach. So I really think that those experiences are very important to be incorporated in many places that we work. But I wanted to hear from you. What did you take from it? Any remaining question on research on suicide prevention? Mansurat, please.
I think this is going to be a question. I know that we talked about so many areas, but I just really wanted to understand if, we are looking also into some of the cultural, support, cultural systems that we do have, and really just systems as well, and how that could impact the mitigation and reduction in suicide. Because we do have communities where people, the only reason why they don't even consider suicide is religion. So, and they find it to be boring. It's not even something that they want to think about. So, in some way, this might not be the most, would I say, logical way of solving this, but I think for some people, they really find, like religion and some cultural practices to be something that they hold up to, to prevent them from doing such. So my question would be that how can we incorporate this in our research or really understanding the impact of this in, mitigating and preventing suicide? Thank you.
That's such an important point, and we have thought about that in our work with Indigenous communities because there is a cultural taboo around suicide, and so it's really interesting. It's like we don't really want it to be taboo, but sometimes a taboo or a cultural or religious belief can keep you from engaging in the act. So it's an interesting tension there, and I don't think it has to be a dichotomy like someone was saying earlier. I think there is a way for folks who are struggling with it, not make it stigmatized, but still support cultural and religious beliefs around, maybe it's more around messages of life as opposed to suicide. But I think we're just starting to get there, but I think it's such an important point. So thank you for bringing it up.
Vijay, please.
Yeah, great question. I think one other point to what Mary was saying is we need more research to focus on the resilience factors that a lot of these communities, especially communities with a lot of collectivism approaches have. I don't think there's a lot of awareness of that. And as I had noted when Mary was presenting, when Lisa was presenting earlier today about this dichotomy of not just training or adapting, engaging with the communities where we want to get the work done, but also thinking about how that work should influence the research community in being able to listen. And often in global health equity, we talk about capacity listening. So really, as a researcher, when you go and think about what would be the benchmarks that you would have to change your narrative and understanding and to really understand what the community is trying to tell you.
On the note of culture and religion and suicide, a lot of our ethnographic work in Pakistan was really anchored and focused on how does religiosity, how do these systems of thinking relate to how a woman experiences and navigates her suicidality. And there's so much power and complexity in that. And so what we did was develop a grounded theory that really anchored in this to give us targeted mechanisms that we could leverage in our interventions to really leverage like the power and the strengths of it, but then also address some of the risk, right, that might be with it being taboo, or you can't speak of it, or if you do it, right, you will be punished eternally. And so we've directly incorporated a lot of that, and it's been really meaningful in a lot of the work that we've done.
Any other aspect to be discussed? No? Pamela, please.
I just found something intriguing that Lisa Wexler spoke about, which was this idea that how difficult it is to predict, right? People that are at high risk for suicide, the low number of suicides that are completed, and yet people who are at lower risk have much higher rates of completion of suicide. So it's and I know there's research on how do we assess risk, but it seems like this is a particularly interesting one to dive into, to understand why is there that unexpected difference, right?
Mark, please.
I could say a little something about that. Actually, the risk in people who are low risk, or the rates, are actually lower. The issue is that there are so many more of them, right? So if you have 1 or 2% of very high risk people who have a certain high rate, but then you have 98% of people who have a low rate, that group will still account for a larger proportion of all the suicides. And so that's the thing that we face, and probably why some of these upstream efforts are really largely going to be more important, or at least as important as clinical efforts, because otherwise you're only affecting that smaller high-risk group.
Thank you. That's great for clarifying that.
Stephen, please. No.
Yeah, no, I guess I would just say it's a both and issue. I think we don't want to rely on the ability to feel like we can definitively judge what someone's risk is. And 50% of people who die by suicide in America do so on their first attempt. So it's going to be really important that we identify ways to put protective strategies in place for people that will never come to our attention. And at the same time, I think we have been utilizing EHRs and claims data in the United States to try and use risk algorithms to take a large pool population and shrink the pool down. So we can't definitively say on a one-to-one basis who's going to be at elevated risk, but we know the people that are in this much smaller pool are at a much greater risk for a suicide attempt compared to all the other people in the pool. So it's an advanced way of screening. But what Lisa Wexler's always saying, or I'm sorry, Lisa Horowitz is saying that, you know, the function of a screener is not actually to identify who's at risk for suicide. The function of a screener is to identify who needs additional assessment that would then inform what the next step of treatment is going to be. So yeah, I close with that.
Pero construyendo sobre lo que la
I'd like to build on what Pamela was asking. If we look at mental health globally, many middle-income countries and low-middle-income countries are starting to see, or they're building their electronic clinical files, and the question is how they can find low-cost electronic models that they can use not just in cities and academic centers, but also in middle-sized cities and rural settings, not just for patients who have attempted suicide, but more precisely to identify the groups of patients at risk of attempting suicide. I'm not sure that the global mental health literature has made strides in this regard. If I'm wrong, please let me know. I think that is a very important statement. I think it speaks to the importance of this symposium. We have to see how we connect this with what is being done in research, and also how do we also take into account the research done at the population level. So that's what I would take away from the last panel. What often happens is that we work from different vantage points, different perspectives, but we don't connect it all. So in many of our countries, we need to promote more research. That is essential. We need to make full use of the evidence we have. A challenge for our countries is how to adapt some models. We don't need to start from scratch. When other countries have done research and when we have seen that those models are effective, we have to see how we can factor in cultural differences so that we can continue to develop more intervention proposals, especially at the community level, taking into account minorities and indigenous groups that may have very special features. So that is one thing I am taking away from this meeting. I hope we all take back this message to our areas of work so that we can continue to work systematically. We mentioned the risk for health professionals. We also need to look at mental health professionals and how we take care of ourselves and how we take care of each other. So again, from my clinical standpoint, I would say that this is another major challenge. We need to take care of our mental health so that we can continue to be part of professionals who are working with individuals who are highly vulnerable emotionally, and evidence-based models give us very relevant information as to how we can develop these collaborative working groups, where there's groups that get together, consultants to exchange experiences, and even some interprofessional groups, so not just psychologists and psychiatrists, but groups that are also open to other professions so that we can develop a more comprehensive approach. I think it is important to do this at the country level when working with research, and that is in turn going to have an impact on public policy.
Any other comments or question? We are reaching the final themes, final considerations. I think that is something that became very clear and super obvious, is the relevance of the intersectoral work here. I think in mental health, this is one of the areas that would most benefit from really engaging with all sectors of government and administration, or we won't be able to succeed. Anything else? Mark, please.
Sorry if you'll allow me one last comment. I think my reaction to the whole meeting is that it's great to have this discussion and we need to continue the discussion. And so I just wanted to mention that the International Association for Suicide Prevention is holding a Pan-American conference in Minneapolis from the 19th to the 22nd of November this year. And I'm co-chairing it, so if people are interested in attending, please come and speak to me or reach out. And we hope that as many people can come to continue the conversation as possible.
Please.
I actually would like to send a question for the organizers, for PAHO and NIMH. I noticed by the presentations that it's so diverse, the Americas and South America and some specific countries, meaning that we are in very different stages in terms of research, in terms of prevention, and in terms of promotion as well. And my question is how we can somehow help and collaborate, and how PAHO or NIH will help to prevent and also increase the need for research in those areas. We know that has been discussed here a lot, the use of guidelines, and I advocate for them. But the problem sometimes is that the guidelines are based on research, and most of the research still come from high-income countries, many times from Europe and regions that does not reflect our realities. So my question is how PAHO and NIH will help in this sense.
I can start. One of the things that we have been discussing here during these days is that we hope that this is just the beginning of forging connections. So we discussed different possibilities that I would be very interested to move forward. I think one of the areas that we could advance is taking each aspect of live life and go deeper into those specific areas with the specific symposiums on that. There are areas that are more advanced in research than others. So this is something that I would be interested to discuss with our colleagues in NIMH, how we could be promoting that. But we also count on you, researchers in this region, to be connecting us to what is being developed, to the evidence that is being created. So we would be in a better position to challenge global guidelines when they exist, or even try to create opportunities for doing the things here in the region with the necessary adaptations for the countries in our region. Most of the time, what we do is to use materials that are already available. There is plenty of material available from the WHO, but when we work with the countries, we collaborate with our office in the country level, and we do the necessary adaptations for the implementation of those guidelines. which usually has been very well accepted and successful. But we are also open to do it in different ways. I think our colleagues in NIMH would also like to mention research opportunities. Yeah, you can.
Thank you, Diane, for your...
Just a second, if I may. Dr. Hennes, you wanted to mention something? Please.
Yeah, thank you so much. And of course, my particular interest, and I like the question about the fact this is relevant to the region, is that the region of the Americas actually, of all the WHO regions, of which there are 6, is the only region where the suicide rate has increased by 17% in the last 2 decades. So in terms of the global stage, there's a particular problem in this region. And I think it's shocking. The other regions have plateaued or have been decreasing. So I think the questions raised here are particularly relevant to our region because we have a tremendous problem compared to the rest of the world. We know some of the answers. We know that there are many more questions than there are solutions. And we know unless we do something to change the trajectory of this problem, we are going to get worse. So I think this discussion is timely and it's very important because if we're going to change the trajectory and the arc of what's happening now, we have to come up with solutions very, very quickly. So I think very helpful meeting, brilliant opportunity to learn and to share ideas, but this is just one step along a journey. And I think I'm glad to hear that Mark has shared with us an invitation to this meeting. I trust there'll be opportunities to discuss it further there and also to develop real actions and interventions that can reverse the course of suicide in this region. So that is my very vested interest on behalf of the department and on behalf of colleagues and on behalf of all of us. We have a big work to do to change the crisis in our region.
Gracias, Renato. Gracias, Dr. Hennes.
Thank you, Renato. Thank you, Dr. Hennes. I believe that we're going into the closing session now. The first thing that comes to mind, well, first, I thought I would do this in English, but there was a session today which made me change my mind. My first language was Spanish, and that is the language for my heart, for my feelings, at least in my case. Darío showed a picture of his son who was 19 or 20 years old at the time, and I was moved. I was moved to tears. I had the privilege to work with many patients in different places, including emergency rooms, patients who were hospitalized, and I have lost patients to suicide. I've never lost a family member to suicide. The pain. I understand that there's 97,000 people in the Americas who died by suicide in 2019. So the pain those 97,000 individuals must have felt in 2019 alone. Paulina showed this to us. It's been 20 years and we could see the pain in her eyes. The pain is undescribable, as she said. And I felt that even though we're looking at science, or this from a scientific standpoint, but it's also about pain and sorrow, as we see how the figures are going up in the region and how the problem remains unsolved. So I decided then that it would be best for me to speak in Spanish. So I'd like to start by thanking the individuals and organizations who have participated in this event. We began planning it, designing it, and dreaming about it more than 2 years ago. And we had to deal with many different circumstances along the way in order to be able to forge a partnership between NIMH, which is an institution devoted fundamentally and exclusively to advancing mental health science through direct research and by funding research, and an organization like the Pan American Health Organization, which is an international health agency, which is the leader in the Americas and elsewhere in the world. So the question is, how can we work together and what can we do? And we begin with a hypothesis, and it is, there is a value, and it's the title we have in front of us, in forging connections between the two agencies. And we found that the two main groups we worked with were researchers on the one hand, and representatives of the member countries of the Pan American Health Organization. So we asked ourselves, what's the value of bringing these two groups together so they can talk to each other? And we understood and we thought that there was much value, there would be much value in this, and now I can say that what we have done exceeds my expectations. I think that the exchange between countries was valuable. Also in the presentation you made, Pamela, about Mexico, also a dialogue at the country level and among different levels or different regions is important, also different professions. We have psychiatrists here, some psychiatrists who work more closely with media. There's others who work in other areas, but there's other very important stakeholders like multilateral development agencies. We have the World Bank and the Inter-American Development Bank here, and we also had USAID, which is a bilateral agency. So to answer your question, Diane, as to what will our role be in the future in continuing to forge these connections, we'll have to see. The people who were involved in developing and preparing this are many, and I would like to just mention a few with a special note of thanks to Renato. Renato, to you and your team, Dr. Hennis and Lou Davis, thank you for everything. Amy and Sarah from PAHO, thank you very much for everything you've done. To my team from the National Institute of Mental Health, Vidya and Stephen, I truly appreciate the work you've done bringing together the domestic research and the global research perspectives together in this process. It's very useful for us.
Also, the NIMH communications team who have been working so hard in this process. One of the most important questions I had and have attempted to better understand it over time is what are the future entry points for research in suicide prevention? And this also leads to mental health research. And this event was actually considered looking at the Live Life focus, and that's why we saw the 4 components that were represented throughout our agenda. And although Live Life has a lot of theoretical focus and some practical research, as Brandon pointed out, there are some research areas that need to be further developed, not only looking at implementation, but also to see the emotional regulation and impact on suicide rates and suicide ideation. NIMH is presently supporting WHO in pursuing this type of research in some countries in the world, including one in the Americas. But there are other entry points that are also important. They're not all encompassing, I do realize that. But from the point of view of science, one of the most often asked questions is how can we implement the interventions that we're working on? And one way to do it is through implementation science. However, listening to people who are working at the Ministries of Health and administrations such as Dr. Eduardo Ace, I wonder if there is an opportunity to rethink some of these questions, not only with members of the community, but also some policymakers, and that way redesign some of the research questions, understanding how health systems perform and work at present. This, to me, was extremely valuable, and I'd like to thank each and every one of you for your presence here, for having devoted 2 days of your time and agenda to attend this event and share your experiences. From the NIMH Global Health Center, we are devoted and committed to continue supporting applied research in global mental health, not only with clinical experiments, but also what Diane Machado presented, research using existing data and on a secondary basis using that data. The center has many financing opportunities that remain open. And a few moments ago, we saw on the screen on suicide prevention. If in Google you put RFA, NIMH, RFA MH25160, if you enter that on Google, you will specifically find that application for resources. It's designed for low and medium income countries. There are other opportunities for high income countries, but that is for the low and medium income. So what we'd like to do is thank you all. We have drawn many lessons learned, and we're going to be permanently focused on whatever progress you can make. And all of us around this table, and we will welcome new actors also in the field. Thank you so much.
Let me also start by thanking our colleagues from NIMH for all the work that we have been doing and that culminated in this very successful symposium. Thank you very much, Leo, Vidya, Stephen. The collaboration has been fantastic. Let me also thank my wonderful team, Claudina Caetano, Amy Tausch, Catalina Ortuzar, Arantxa Cayon, Maria Migliora, Mechi, Ana Soria, Natalia Landines, Mansurat, our colleagues from WHO that have also been together with us, especially Pumi Bandara, who has given us a lot of support in the last month. We had 2,000 people entering the webpage of PAHO created for this symposium yesterday. So this is a sign of the importance of this topic. And I think this is also a sign of how people are eager to learn more about suicide prevention. Another very important aspect of this symposium to me has been the diversity of participants, which again connects to the importance of intersectoral work. We have colleagues from the World Bank, the Inter-American Development Bank, USAID. We had colleagues from embassies, the Organization of American States. So we need all of you to advance suicide prevention in the Americas. I think there are also some points that I wanted to bring before we finish the symposium. PAHO is really committed to advance suicide prevention in the Americas. You know, many times during those discussions, I was listening to very important technical elements that would need to be deployed or implemented at the country level. And sometimes I was trying to understand how we could be helping countries to integrate those interventions in environments that many times are not yet prepared for that, don't have the professionals that would need to implement those interventions. But this helped me to think that one of the important work that we need to do with member states is start by creating the appropriate governance for suicide prevention. We need to help countries to strengthen or create suicide prevention strategies, because these are the foundations for the integration of evidence-based and evidence-informed interventions. And we really want to work with countries very closely in supporting them to do that. We are at the final stage of developing what we will call a suicide prevention initiative in the Americas, where we really want to put everything that we can at the service of countries to strengthen those elements that I have just mentioned. Also, creating awareness about this problem. So trying to find ways that governments put suicide prevention at the top of the public health agenda, because that's not the reality today. So you will be hearing from us in the coming month when we will be making the suicide prevention initiative more concrete. We have also done agreements recently. We just signed an agreement with the University of Toronto, and we are going to be launching a series of webinars on suicide prevention, going deeper into some of the topics that we had discussed here today. And we continue a very intensive work in all the member states of the Americas, with our regional advisors, with the mental health specialists at the PAHO WHO country offices, who are always very connected to the ministries of health, helping them to integrate these interventions into the public health system. So there is a lot that needs to be done, but there is also a lot of energy on our side, and we saw the same energy from the representatives of the ministries of health that were here present. So thank you again to all of you for being here with us. You know that you can count on PAHO to support you, Ministries of Health, and I hope you will be joining us, our future events, and I hope you will go back home with more information that you had before in all these different areas that are so important for comprehensive responses to suicide prevention. Thank you again very much. I wish you a safe return home, and we'll keep in contact. Thank you. Have a good weekend.